أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. صدق الله العظيم. I welcome you all on behalf of the Hashmanis Hospital and the OSP Karachi. This program, this pre-Congress workshop, is conducted by the Hashmanis Hospital. As you know, that refractive surgery and the procedures being done on Keratoconus, Hashmanis Hospital is in the forefront. All new procedures that are introduced, we are doing it here. So, as you will see in our specialists and panelist talks, there's a lot to learn today. So, I think they're going to play the national anthem first. After the national anthem, may I request Professor Salim Meher, he is the president of the USP Pakistan, to kindly come and formally inaugurate this session.
Thank you, Misbah. And ladies and gentlemen, it's nice to see you all here and some senior ophthalmologists sitting in the front row. And as Misbah put it exactly and correctly, that we are thankful to OSP Karachi for holding this conference and also giving us space for this wonderful symposium. And thanks Hashmanis. And you can see senior and junior Hashmani both here. और हम इनके साथ ये नहीं होते कि सिर्फ साइंटिफिकली आते हैं, हम दोस्ती यारी में भी बहुत आ जाते हैं इनके साथ, ठीक है. सो ग्रेट टू सी एवरीबडी एंड आई सी लॉट ऑफ गुड पीपल, गुड मैन हु हैव बीन वर्किंग हार्ड इन कॉर्निया रिफ्रैक्टिव सर्जरी एंड कमिंग फ्रॉम पेशावर locally and all parts of Pakistan. So nice to see you all, and please start the session. Thank you. Thank you.
As you all know, today's session is divided in two halves. The first half we are going to discuss mainly about LASIK and refractive surgery, and in the second half we are going to discuss about the keratoconus. We have a list of panelists who will be sitting here. They will show you some interesting cases, ask your opinion, and they will give your opinion also. So may I request first to come and have a seat Dr. Sharif Hashmani. Besides being the force behind this these meetings, you know, he is an excellent refractive and cataract surgeon. When phaco was being introduced in Pakistan, he was among the first to master it. And LASIK and femto LASIK and all the procedures on cornea and in keratoconus, he is among the pioneers. Next is Professor Mahfouz. May I request Professor Mahfouz? We are very thankful to Professor Mahfouz. He comes all the way from Peshawar to share his expertise and his knowledge with us. Thank you, Professor Mahfouz. Qasim Latif was supposed to be here, but unfortunately, because of the ailment in his family, he is unable to attend today. May I next invite Dr. Professor Israr Bhutto. Professor Israr Bhutto is the professor of surgery, professor of ophthalmology rather, in Jinnah Postgraduate Medical Center, the prime teaching institution in Karachi. And he has long been associated with Al Ibrahim Hospital and is well known amongst the trainees because he used to be the training supervisor there. Thank you, Dr. Israr. And may I now request Dr. Azhar Nafis to kindly come and have a seat. Most of you know Azhar Nafis as a glaucoma surgeon and glaucoma specialist, but I think his knowledge and his expertise in refractive surgery and his keratoconus is not next to anyone. So I'll hand over all these panelists to Dr. Noman Hashmani, who's going to moderate the session. And Noman Hashmani also, you know, he's at this early stage and his early stage of his life. He has done a lot. He has written, I can't remember now, more than 30 papers in international journals. And he is not only an expert in refractive surgery and keratoconus, but I have seen him doing vitreoretinal surgery and is equally good there. Noman Hashmani, please.
Hello. So, first of all, thank you for that wonderful introduction, Dr. Misbah, and thank you to all the panelists that have shown up from all over the country and taken the time out to guide us and sort of show us how to do refractive surgery in the, I'm going to take this session a little bit quickly because obviously we have two different, hugely different topics to take care of. And the next few slides, we're going to be talking about topography. Topography should be a session on its own, and therefore we're going to take this a little bit quickly so we don't waste our entire session on just talking about topography. So it's a simple question. In the following next few slides, should we be doing LASIK in these eyes? Some of these are just topography, some of these have epithelial mapping, some of these have corvus as well, just as a disclosure. So this is the first topography of a patient who's 33 years of age. He's a minus 4.75 and minus 4.5. So if any of the expert would like to take the mic and say what they see on this topography so we can all sort of learn from that. I think you can turn the mic on.
Ji, Assalamu alaikum. What I can see on the a black screen. It's not very clearly visible, Noman.
So what do you want me to tell you? Let me.
आप बता दें the bottom right, the posterior elevation.
Okay,
so the readings is
plus 11 on the right eye is on the center, and the left is about plus 18.
And what about the y coordinate?
Okay, so the y coordinate is the pupil center is plus 0.08 and the thinnest local is minus 0.20, and the x coordinate is minus 0.67.
No, the y coordinate. It will be the second one.
Of the thinnest local?
Of the thinnest location.
Yeah, so the thinnest location y coordinate is minus 0.20 millimeter.
Minus 0.20. the posterior elevation is slightly higher and on the both sides actually. So it will be like a subclinical or a suspicious case. So I would like to do something else like epithelial mapping.
Okay. Anyone else want to? And let me just show you the Bellin embryos display as well.
That's helpful.
Yeah, Bellin ambrosia on one side is absolutely fine. The other one is in the yellow, but there is, the anterior elevation is fine actually. It's just because the anterior elevation gets compensated. It was basically the posterior elevation that was in the suspicious range. So I would like to confirm it either with the epithelial mapping, and if the epithelial mapping doesn't work, then I would like to do the Corvus.
Okay, so for those of us that didn't understand what he was trying to say is that there are certain amounts of posterior elevations that are coming. You can actually see them here. You can see the enhancement of the posterior elevation on both maps. That's the right eye, and you can see the posterior elevation here and the posterior elevation on the left eye as well. And you can see that the D in the left eye is yellow. The D is the only predictive value that will tell you, that sort of predicts whether this person will develop ectasia or not. Now, this is why I put this case up, just to show you that there are borderline cases.
Can I just add something on the yellow? You very often see the D's here in the yellow, but that's most commonly because of the high astigmatism rather than because of the pre-keratoconus. So don't be afraid of the yellow. If it is less than 1.86, it's very often, if you see high keratoconus, high astigmatism patients, it is yellow, but that is not an abnormality. That's usually a regular astigmatism.
So that is a brilliant point. So let me ask the audience. I want to see if anyone can answer this.
I would like to comment on this. Could you please show the first slide, please? Now, just look at the slide. मुझे इस वक्त किसी भी किस्म की कोई भी figures नज़र नहीं आ रही, but just tell you कि how to look at the topography. अगर आप सिर्फ topography को देखें तो just look at the colors, ठीक है? Right eye में आप देखते हैं your colors seems to be within normal limits, ठीक है? अब आप left eye की तरफ आते हैं तो you can see a little bit reddish area in the posterior elevation. यहाँ पे आपका red flag on हो जाना चाहिए, ठीक है? किसी भी केस में हम topography क्यों करवाते हैं LASIK के लिए? इसलिए कि keratoconus, subclinical keratoconus are contraindicated for LASIK. तो बेसिकली आपको ये एक्सक्लूड आउट करना है, ठीक है? अब ये जो है इसकी लेफ्ट आई में थोड़ा सा सस्पिशन आया, गो अहेड, गो फॉर BNA, जैसे कि नुमान ने दिखाया. नेक्स्ट स्लाइड प्लीज. अब आप बेलिन एम्ब्रोसिया देखो, राइट आई में आपके पास मेजर डेविएशंस आती है एंड दैट शोज के एनहांस इक्टेजिया जब का स्कैन किया है तो दैट लुक्स टू बी ओके, फाइन, सो यू आर ओके. बट look at the left eye में भी if you look at the pictures they are all okay, pictures are okay. सिर्फ deviation, total deviation, the D value has been increased. मुझे इस वक्त नज़र नहीं आ रही है लेकिन the cut off value is around 1.32. इस वक्त कितनी है इसकी नुमान?
It's 1.95.
1.95, a little bit higher. 2 से above जाती है ना तो highly suspicious of keratoconus. अब ऐसे पेशेंट के पास आपके पास 2 ऑप्शन हो जाते हैं, फर्दर इन्वेस्टिगेट करें या ऑब्जर्वेशन पे डालें एंड आस्क हिम टू कम बैक अगेन 2 वीक्स 3 वीक्स के बाद आप रिपीट करें. समटाइम्स व्हाट हैपेंस, डिहाइड्रेटेड होता है, समटाइम्स आपकी गर्दन ऐसी होती, कभी ऐसी होती, तो एलिवेशंस कभी ऐसे आ जाएंगी, कभी ऐसे आ जाएंगी, ठीक है? एक टोपोग्राफी में ना आप रिजेक्ट कर सकते हैं, एक टोपोग्राफी में ना हम उसको कह सकते हैं गो फॉर LASIK if the topography is just like that. So definitely I would ask for further investigations in this case, and if you don't have the option, then I would say come back again after 2 weeks by putting lubricant eye drops. What did you do?
Okay, so this particular case I've just put to highlight the 2 things. The yellow D because of high astigmatism, as Professor Mahfouz indicated, and what I put this as is isolated posterior deviations. So the lubricant part of it usually comes on the anterior, but it's a very, very good point. Okay, so why do you think that a high astigmatism would give you a higher D value? Can anyone sort of think of why that can happen? D value का astigmatism से क्या ताल्लुक है? So the astigmatism is not in the prediction of the D value. The D value looks at 5 things. It looks at the anterior, the posterior, it looks at progression, it looks at thickness, and it looks at age. So it doesn't, and it looks at the thickness deviation. So it doesn't look at the astigmatism, but what it's doing is, because when you have a high astigmatism, you also have a high progression from the center to the periphery. So via the progression, you get a higher D value. So you have to keep that in mind. Now, unfortunately, I don't have the other tests in this particular case, but this was a very, very good case to sort of highlight these 2 points. Okay, so now the next case. If anyone would like to comment on this, -3, -1.5, -2, -1. I will give you the thinnest point is at about 532 with a -0.42 y value and a +17 posterior elevation. And on the left eye, it's a +29 posterior elevation. And I'll also show you the Belin-Ombriosi. Now, if any one of the experts would like to comment on this.
पीछे वाली slide पे जाएं.
Sir.
You know, I've described in the topography there's something called as embryo type of elevation. So this one is the bottom right, the posterior elevation is like embryo type, and it's much more than as before. And if you look at the curvature maps, there's a SRAX there as well. The upper prong is tilted towards the right hand side, and that looks more than 22. I cannot see the Y coordinate. Y coordinate कितना है thinnest location का?
-0.42.
और thinnest location कितनी है?
Thinnest location is -0.42.
नहीं, वो माइक्रोन में होगी.
Sorry?
माइक्रोन.
Millimeters.
जी.
532.
532. As compared to previous case, this one is more looking like a preclinical keratoconus.
Okay. Any points you want to highlight here?
I think this is the back and the front, and in the yellow. So this is the case of looks like a subclinical keratoconus. So if you are going, you will end up with the ataxia. So I think it's better to review and wait again.
Excellent. So what they're trying to say is that if you see these 3 maps, you've got something called the elevation map, that what everyone knows. This is the enhanced elevation map. I'll explain that in a further lecture, but what it does is basically enhances the elevation. And then you've got a difference between the two, where you're seeing in the anterior elevation, the difference is high enough that it's sort of highlighting it. Posterior, there is an elevation that enhances, but it's not big enough that it sort of enhances itself. Now, is this person subclinical keratoconus or not? We're going to go towards something called Corvus, which is the biomechanical assessment of the cornea. Now, with the biomechanical assessment, it's basically looking at 4 parameters: the stiffness parameter, integrated radius, ARTH, and DA ratio. Now, if any one of the experts would like to comment on this particular slide, that would be wonderful.
Though the Corvus is not meant to diagnose keratoconus, but it actually try to exclude those patients who can have a corneal ectasia actually by looking at the corneal stiffness. So if you look at the CBI, the corneal biomechanical index values, they are all in green in the right eye as well as in the left eye. But if you look at the TBI, the tomographic biomechanical index, then again it's in the greener side. So safer side पे है. But still, I would say जब ऐसी topography हो तो further investigate करो to exclude keratoconus. With this Corvus तो आपको ये बता रहा है कि yes, you can go for LASIK, but still, जैसे डॉक्टर इसरार ने कहा कि this is highly suspicious case who can have corneal ectasia later on in life. So मैं इसकी corneal epithelial mapping कराना चाहूँगा, which is much more sensitive in diagnosing keratoconus at early stages rather than Corvus.
Okay, so
Noman, देखिए Corvus ना, Corvus stands for tonometry, corneal topometry. It is just that before that we should have done, as Dr. Sab said, epithelial mapping or epithelial thickness. ये तो आपको ये बताता है कि आपने उसकी लेसिक करेंगे कि नहीं करेंगे, लेकिन उसको केराटोकोनस है कि नहीं है, that will be more. Corvus is more suitable if you've got a found first keratoconus. But this one, the patient, this one on the topography is not found first day. It was more like a subclinical keratoconus. So to rule out the keratoconus, whether the patient has or has not that, we should have done epithelial thickness or epithelial mapping before going to Corvus.
Okay, So this particular case, when we had this case, we didn't really have the epithelial mapping. So I don't really have the epithelial mapping. But just to go over Corvus, because there's a lot of confusion what Corvus can and cannot do. So let me just explain to you what the data actually says. So Corvus is, I sort of disagree with the both of you, because Corvus is an excellent tool to diagnose keratoconus. So when you get a new tool, you have to first prove whether that tool is as good as the old tool that has come, right? You have to prove that before you go on to saying that this is a better tool or not. So if you are looking at frank keratoconus patients, the Corvus is excellent, almost 99 to 98% sensitivity specificity, and it is amazing at differentiating. So that was the sort of the first study that came out, and it is very good at diagnosing keratoconus. However, when you go into, like Professor Mahfouz said, when you get into the subclinical keratoconus zone, what they've seen is that it is, while it is good, it is not perfect. So it is about 80 to 85% sensitivity and specificity. What that means is that you will miss 15 to 20% of patients in false negatives and false positives. So yes, I agree with you that it is not amazing at picking up. So there should, and I agree with you that epithelium should have been done in this case.
No, but just let me clear one point. You repeatedly said Corvus is a very good tool for diagnosing keratoconus. I would disagree with that. I would disagree because of the reason there's a meta-analysis which was published in 2025, which is this year, and that was on 15 cross-sectional studies based on that, and that was the meta-analysis of that written by Wang in Cornea Journal. It says that no one investigation, when it's a keratoconus, subclinical or the preclinical, then you can diagnose it with the topography. But when it's not obvious with the topography, then no single thing can diagnose, including the Corvus. फिर आपको करना क्या है कि you have to do the Corvus, you have to do the epithelial mapping, you have to do the ultrasonography, high-speed ultrasonography, and genetic testing. So these combine. There's something called, देखें जब आप कॉर्विस करते हैं ना तो कॉर्निया एक दफ़ा इंडेंट होता है, फिर वापस आता है, फिर दूसरी दफ़ा इंडेंट होता है. दैट इज़ कॉल्ड P1 एंड P2. जो P1 और P2 के दरमियान में जो एरिया होता है दैट इज़ कॉल्ड ऑरॉक, AUROC. वो जो ऑरॉक होते हैं ना उसकी सेंसिटिविटी इज़ 89% when you take all the 4 parameters. But when you just take only the Corvus, then उसकी जो sensitivity है that is 62%. 62% is not very high. So I would disagree that it's a very good tool for diagnosing keratoconus.
Let me just clarify, I'm talking about combined tomography with Corvus. I'm not talking Corvus on its own. So we've never used Corvus on its own. We're talking about combined tomography with Corvus.
रात को जो हमारी बात हो रही थी नुमान के मेरा ये कहना है कि जब तक cornea has to be biomechanically weak and then it will show cornea has first the cornea become biomechanically weak and then it shows the morphological changes on the cornea on topography. So if topography is normal, then if topography is normal, can be normal, and Corvus can be abnormal. It has just started. But if Corvus is normal and topography is abnormal, like in this case, I would go for LASIK surgery after doing epithelial mapping. If mapping is okay, then I'll go for it.
If the mapping is okay, then fine.
So your point of view was last night you said is specificity and this thing is 80%. That is what. So based on only on Corvus, if Corvus shows, my understanding was that Corvus will show cornea is biomechanically weak and now it will show on the topographically. Morphological changes will appear on the topography. That is not correct.
So that was a very good discussion. I'll repeat it here. So what I said was that in theory, your biomechanics will get worse and then your anatomy will get worse. In theory. But the tools that we have today for judging biomechanics are not sensitive enough to pick up the biomechanical changes before the anatomical changes. So over the years, we figured out that Corvus alone is not good. Corvus with tomography sort of enhances things, but it is not perfect. The first changes, in my opinion, as Professor Mahfouz said, absolutely epithelium is the way to go. If you see a normal epithelium, that means in about 99% of the cases, this patient is probably okay. But even if you're then seeing a little bit of changes in the posterior sort of elevations or anterior elevations in the topography, it's always healthy to sort of wait. Sometimes the topography changes are because of dry eyes. So you get this anterior elevation on the topography and it's only occurring because of epithelial hypertrophy or sometimes contact lens use. So the epithelium sort of has a lot of information that it can offer you. So that was the sort of the discussion. I think that was a very healthy discussion. All right, moving on to the next case. Okay, so again, Asfar Saab, if you would like to comment on this particular case.
If you look at the topography, seems to be okay, though कि मुझे number कुछ नज़र नहीं आ रहे हैं. But then refraction, अगर आप देखते हैं 35-year-old, it's
41K reading, 42K reading, you've got a thinnest local of 562.
562, good enough. It looks to be symmetrical. Astigmatism नज़र नहीं आ रहा, वैसे मेरे ख्याल में है नहीं इसमें.
बहुत minimal सा astigmatism.
Minimal सा है. Even refraction में भी astigmatism नहीं है. So if you look at the topography to me looks to be okay. How is the Balin Ambrosio?
There you go.
Balin Ambrosio, look at the Balin Ambrosio, आपको देखने ही से पता चल रहा है, that looks to be okay. The total deviation of all this जो summarize करते हैं, the value is less than -1.32, बल्कि negative में है, तो it's quite good. So even with this topography, if I have this topography with BNA, I would go for LASIK. मैं मज़ीद कोई investigations के लिए इसको बिला वजह नहीं refer करूँगा.
Is everyone in agreement? Everyone in agreement that we are going to do LASIK in this case?
LASIK or the FEM2? FEM2 is bigger because the K values are little bit down, so I would like to go for the FEM2 as the safer than the laser.
We have got the habit of doing all the three tests. We have got the habit of doing all the three tests, that is topography, epithelial mapping and Corvus in every patient that undergoes LASIK. So I think this is the same case that Noman wants to show you the surprise.
Now would you go for LASIK?
If you look at the epithelial mapping, it's not that bad. अगर आप normally epithelial mapping देखते हैं, तो what you see is that central as well as inferior and nasally it's thicker. Temporally and superiorly is thinner normally में. So superiorly तो it's thinner, but then yes asymmetry है दोनों में asymmetry है. Could be because of the dryness.
You know, you do it as a routine, but if you don't do it as a routine, what makes you think that you should do epithelial mapping?
Sir, for me,
मतलब आप तो routine में करते हैं ना, फर्ज करें मैं routine में नहीं करता. What should make me think I should have done this?
Okay.
आप पिछली वाली पे जाएं अभी, topography पे जाएं.
I'll cover your question. That's a very good question, very relevant question. The problem is, and I'm not talking about any of the experts here, I'm talking about in general in the world. What we're doing is we're looking at topography and we're saying go for surgery. We are not treating topographies, we are treating patients. So that means dry eye assessment should be part of it. This patient, I would not go for surgery in this patient before this epithelium settles down. This is not a keratoconus case. Asfar Saab was absolutely right that you are not seeing much asymmetry. This is not a keratoconus case. This is a dry eye case. So if you don't have epithelium, you will be looking at Schirmers, you will be looking at T-buds, you will be looking at all of the other stuff that you have. But that all sort of comes to this particular thing. You get this massive epithelial hypertrophy. So everyone that has ever done LASIK, if you come and you see this sort of, or if you've seen someone that has bothering you after your surgery and has said that, oh, meri aankh mein chuban khatak hai, and we've had, every one of us have had this patient. मेरी चुभन है, खटक है, मैं LASIK करा के तंग आ गई हूँ. I'm sure everyone, you get his epithelium done or her epithelium done, and I can guarantee you there will be an epithelial hypertrophy. This person should not be going under LASIK before his epithelium is corrected. For whatever reasons it's in hypertrophy, and that can include, so I've been doing a lot of work on trying to figure out what dry eye causes are in our country. So there are quite a lot. So number one, I'm going to say one of the rarer causes, but it's not so rare that we don't look for it. Look for lag ophthalmos, please. You have someone with lag ophthalmos, meaning his eyelid is not closing, and you do LASIK on this patient, he's going to be bothering you for the rest of your life. He's not going to get better. Number two, bike riders, especially those that are not wearing their helmets. Extremely dry patients. You do patient on this LASIK on this patient, they're going to, and you don't correct his lifestyle, you're going to have a problem. Number 3, kajal and surma users. So the kajal and surma that you're getting, I don't know what the direct effect of kajal and surma is, but the kajal and surma that we're getting in Pakistan has almost 50% lead inside them. So please ask even your cataract patients, please ask them, are they using it? And again, the cataract mein bhi wahi cheez aa jati hai. Because when you do the corneal sort of section, you're going to sever their nerves, they're not going to come back. So you can see, I was going to ask this question, why is this sort of centrally hypertrophied, this person, why is it left eye? So always the epithelial hypertrophy will occur from the inferior side and then go up. And uska reason yahi hai because your eyelid closes in the inferior part, mid-periphery at the end. So that is where your dry eye will start. So for me, I would not do this patient until the epithelium settles down, which can take as quick as 2 weeks to as late as 2 years.
What about the pre-op history? There is the history is the more important, the refractive surgery.
Absolutely.
The detailed history, family history is the important. What about this, any history of the dry eyes or anything, stinging, any foreign body sensation?
So for us, we also do something called the Ocular Surface Disease Index Questionnaire. What that does is it sort of categorizes their symptoms for us, what they have had for the last 2 to 3 weeks. Now, always remember that the anatomy and the symptoms don't always correlate. So these are 2 essential tools that you must combine to get to your dry eye patients. Okay? OSDI plus epithelium, T-bud, Schirmer's, whatever you have.
So it's necessary to go the detailed history. If you have no
Absolutely.
type of this machine, so you have go the detailed study before doing this
Absolutely.
decision for
Absolutely.
the laser.
So do your fluorescein breakup times and do your, I don't do Schirmer's, but do your fluorescein breakup times, please.
Fluorescent available everywhere.
It will tell you a lot of things.
You can go for dry analyzer.
Yeah, so that's so dry analyzer will give you a couple of things. It will give you non-invasive breakup time. So that is better than fluorescein breakup time because fluorescein, you're sort of altering the tear film, and that's why you're not getting actually true results. If you have non-invasive breakup time, you can do mybography and you can do the lipid layers. Those 3 things are absolutely invaluable. You're right, Dr. Mahir. Okay. Yeah, I think I'll do this case and then. Yeah, I think I'll do this case. Yeah. So, any of the experts want to comment on this particular case?
एक तो नुमान नजर नहीं आता.
I will tell you, don't worry, I will tell you. So K readings 43, 44. Okay.
बहुत छोटी है size.
Then you've got thinnest local of 564 and dislocation of minus 0.47 on the Y. And you've got a posterior elevation of plus 14 on the right eye and plus 12 on the left eye.
That's it, plus 14 and plus 12.
Absolutely, sir.
Posterior elevations.
Yes, sir.
लेकिन रेडनेस थोड़ी ज़्यादा लग रही है.
रेडनेस ज़्यादा लग रही है और अगर
थोड़ा
आप
सा
उसकी शेप देखें तो डोनट शेप है.
हाँ, थोड़ा टंग शेप्ड है. और Bell and Ambrosio that shows us. But if you look at the total deviation, it's within the limits. And if you look at the ART max, within the limit. If you look at the progression index, good enough, less than 1 average progression. तो एक corneal epithelial mapping करा लो just to exclude it. Otherwise, yes.
Good. So forget the epithelial mapping and forget Corvus. If you saw this case and you just had topography, would you go for it?
No.
नहीं, थोड़ा सा repeat करेंगे.
Absolutely, agreed. Corvus. Okay, so you got a CBI in the green, you've got a TBI sort of yellow. Now look at this. So whatever. So we'll cover this more in the keratoconus section. But if anyone wants to sort of highlight this, that's fine. But we have more in the keratoconus section that will come later.
It's not a particular donut shaped, but again, yes, थोड़ा सा asymmetry बहुत है. If you look at this, superiorly thinning है, which is normal, ठीक है, लेकिन काफी ज़्यादा thin है as compared to inferior, काफी thick है. ठीक है, inferiorly you can see, but central area में you can see the thinning again. So dry eye analyzer करो, इसका ख्याल में tear film unstable है या there is a history of any trauma, eye rubbing.
Sure. Anyone else?
I think it's less like a dry eye, it's more like a keratoconus.
Okay, so for me, sure. Yeah, mic, please.
there is central thinning in the right eye. And normally in epithelial mapping, there is thickness in the center. So more likely this is keratoconus rather than the dry eye, in my opinion.
Very good. But there's one other history that you should be taking. Contact lenses.
Contact lenses.
So, this looks like a donut shape. I agree. But this is a contact lens user. I would not be making any diagnosis until we sort of stop his contact lens for the next 4, 5, 6 weeks, and then call him back, rescan, and then we take a decision from there. Let his epithelium regularize, and then you don't need to hurry. Obviously, LASIK to karna hi nahi hai abhi for the next month or two until you're absolutely okay. If it comes back as donut shape, which it probably will, because that's what the configuration shows, this will be a keratoconus cake, you're sort of excluding.
It's not the epithelial mapping that was worrying me, it was the posterior elevation. And the posterior elevation cannot be affected by the contact lenses.
Absolutely.
Contact lenses epithelial को तो affect कर लेगा, लेकिन उसकी तो posterior elevation 14 micron है, तो which is in the middle zone, suspicious zone. तो वो तो contact lens से affect नहीं होती.
I agree. So, but there is a condition that was originally described by Dr. Bellin when he made the topographies, and it's known as isolated posterior deviations. So there could be a concurrent cause of isolated posterior deviations with contact lens wear, but
isolated posterior deviation, that's renamed as the posterior keratoconus. उसका नाम change हो गया, that's called posterior keratoconus, and that's a non-progressive condition. लेकिन उसके ऊपर उसमें epithelial thinning नहीं होती.
जो भी नाम आपने रखना है, it's fine. But yes, so that's what it is.
If you suspect there is a subclinical or keratoconus, I think it's weighted because the fear complication of the ataxia, and this is the irreversible and uncorrected vision for the whole the time.
Absolutely, absolutely. That's the message we sort of want to bring across. That if you are at all unsure, please do not do the case, or refer him to someone who has all of these machineries that can sort of diagnose the case for them. Absolutely, that's a very good point by Dr. Isra. Sure.
Routinely, when you do topography, you always ask patient whether they have wore contact lenses. You mentioned 3, 4, or 5 or 6 weeks of non-wearing. Is that the routine, or 1 week is enough?
So it depends
because some people do have this corneal warpage, which can give you wrong topography reading, thinking that's something else. How long you should be without contact lenses, you think?
So it really depends on, one, which contact lens they're wearing. So is it a hard contact lens or is it a soft contact lens? If it's, so majority of the time it's a soft contact lens. Now if they've been wearing it for maybe a year, 1 to 2 weeks may suffice. But if they've been wearing it for the last 10 years, you're going to sort of have to drag that out. So I think the guideline, the rough guideline was that you take into weeks the number of years they've sort of worn the contact lens.
Because I'm asking this because sometimes the patients come from abroad and they said, well, we have very limited time here, can you do our surgery? So it's a message for all those who are doing, or who are young budding ophthalmologists, that don't do anything in haste. Don't just do it because they're asking you to do it. Make sure that they have not worn contact lenses for a certain amount of time. And if that means they are going to miss the flight, or they're going to go away and come back, let it be. Otherwise, you're doing such a case, and then you will be in trouble post-operatively.
Absolutely. That's the message that we want to say. That's a very good point. So for keratoconus, for contact lens wearers, and for dry eye patients, those are the most neglected sort of people. बेचारे उनको हम देखते ही नहीं हैं. I've treated 2 patients of mine for dry eye for over 2 years before doing surgery, and because I treated them prior, and मेरे पास माशाल्लाह, because Abu, I have almost everything, तो उनकी confocals भी मैंने कराए थे, epithelium भी मैंने कराए थे. That's a case that I presented. They were happier with their eye after the surgery than they were 2 years prior. So LASIK is not it's not LASIK that's causing the issue, it's their corneal nerves because of dry eye. Okay, so this is just a quick case that I want to discuss, just to highlight sort of what we all keep seeing, the specialists sort of keep seeing, कि high K reading है तो keratoconus है. So I just want you to see this topography. This person has a K reading of about 50.7 and 46.3. 505 की thickness है इसकी. You can see the anterior and posterior elevations, and you can see the Bellin embryozo display. So this is just to highlight कि K reading अगर 50 से थोड़ी सी ऊपर है, it does not mean that this person has keratoconus. Please, topography के बगैर ये decision आप नहीं ले सकते. Okay, so I think I'm just going to move over now. So this is a case, we're going away from topographies now. 26-year-old male had LASIK about 2 months ago. Still has decreased vision, 636 in both eyes. He has been taking steroids due to a suspicion of DLK, and his last IOP measurement was about 16 millimeters of mercury. What would you suspect in this case? And this was a case that was sort of referred to us from another city in Pakistan because they couldn't figure out what's going on. Why is his vision low? So what do you think?
What about this IOP? You have taken this IOP with the Goldman
applanation? Goldman applanation tonometry.
तो वो तो फिर आपको थोड़ा कम ही दिखाएगा ना?
Yes, glaucoma sir.
क्योंकि ये तो corneal thickness का हो गया.
Corneal thickness is about 480.
I think.
Absolutely.
16 pressure might be pretty higher for these thin cornea on which you do the LASIK.
Absolutely.
Okay, especially you've been pushing steroids in his eyes, you know. So you have to be careful. I think you also need to look at his posterior segment.
I think this is the case where when we use a lot of steroids to just disperse of this DLK, then it leads to pressure-induced superficial keratitis, PISC, pressure-induced stromal keratitis. This is what happens in LASIK patients. और वो जब आप Goldman applanation tonometer से लेते हैं तो आपको मिलेगा 16 weeks.
So how would you diagnose this case?
तो we need to have this. मैं अपने क्लिनिक्स पे कॉर्वेस से इंट्राओकुलर प्रेशर इसका निकलवाता हूँ because we have it. लेकिन ये है कि आप इसमें देखें कि स्टीरॉइड्स को कम करें, start giving any prostaglandin analogs and you will see कि ये इम्प्रूव करना शुरू कर देते हैं. 16 mmHg को आप जो अपने कैलकुलेटर उससे अगर आप कन्वर्ट करने की कोशिश करेंगे तो वो आपको एग्जैक्टली नहीं दे पाएगा जो कैलकुलेटर है. लेकिन ये है कि ये राइकेट टोनोमीटर अगर आपके पास है या ये कॉर्वेस है जैसे हमारे पास है तो हम उससे लेते हैं तो उसमें पता चलता है. लिया था इसका तो बताना जरूर.
मैं बता दूं.
Why was he referred to you? Because of the decreased vision or because of the pressures?
Decreased vision.
तो अगर pressure.
So this is a refractive surgeon in panic.
अगर pressure
की है अब क्यों ये हो रहा है?
अगर pressure 16 की जगह 26 पे है, that shouldn't have decreased the vision.
That's exactly what I want to highlight. So, Asfar Saab is a glaucoma specialist, मैं cornea specialist हूँ. तो cornea वाले जो लोग हैं वो हमेशा cornea को देखते हैं. So this is the anterior segment OCT. ठीक है? This is exactly what Asfar Saab was saying. It's called PISK, which is the old name. The new name is called interface fluid syndrome. So if you've got someone who's taking a lot of steroids and post LASIK, you see this sort of. So you've got this is where the flap is. This is the anterior sort of part of it, posterior sort of part of it. There's fluid in the middle. So when you're taking the pressure is coming back normal because pressure to iska aa raha hai. Idhar ka nahi aa raha. It's not off the eye, it's off the pocket. So what you need to do now is because he's taking steroids for 2 months, you need to stop his steroids and start him on anti-glaucoma medications. And that is why his vision was reduced. He had interface fluid syndrome. Pressure bada, you've got sort of a dehiscence in the middle. Uski wajah se. We've got one other case, Abu Ghai case hai, which is I think it is one of the first cases in the world. We're going to report this in the next couple of weeks. It is interface fluid syndrome secondary to endothelial decompensation. So interface fluid syndrome hamesha is not because of pressure raise. It can be due to endothelial dysfunction. Anything that's going to bring fluid into the cornea.
And in that particular case, we tried, raised the flap, removed the fluid, and put it back. And the patient, for about 2 to 3 weeks, he was very well. He saw 6.966. And then again, because of the endothelial decompensation, he again got the fluid in.
Does it mean that one need to look at the endothelium as well? Because this patient, which is you described, is because of the endothelial decompensation.
I don't think you have to look at the endothelium. because most of the patients are young patients. But that particular case was a post-cataract surgery patient. The reason was that he had previously a surgery done for cataract, and he had an anterior chamber lens in. So we removed that anterior chamber lens, and because of that he developed decompensation, and because of that he developed the edema.
So did you go for a specular as well in this case, because there was anterior chamber lens? Because that must be the cause of this decreased vision and endothelial decompensation.
I didn't repeat your question.
A specular microscopy. Did you go for specular?
Yes, we did go for specular microscopy. He was my patient, and he was kept under observation since very long. And when his this endothelial cell count went down to 800 or 900, at that time we decided to remove the lens and do the cataract surgery. So, so that was the reason.
Why did we go for refractive in this case?
It was already done before. So.
Already done.
नहीं, actually case ये था कि it's been done 10 years back. ये आया था high myope था. So sir put the artiflex. Sir remember artiflex या वो डाला था. Artiflex रखा था.
Artiflex ये डाला था आपने वो कैशे लेंस था.
कैशे लेंस. It's been like more than 10 years.
Sulcus fixated lens आता था Alcon का.
Alcon.
कैशे लेंस. तो he worked nicely, and अभी भी काफी पेशेंट्स हैं जो काम कर रहे हैं. लेकिन इस पर्टिकुलर पेशेंट में ही डेवलप्ड एंडोथेलियल डिकम्पेंसेशन, एंडोथेलियल सेल लॉस शुरू हुआ उसका. और जब ये वाज अंडर माय ऑब्जर्वेशन, एंड जब उसका काउंट 800 or 900 हुआ, तो देन वी ऑफर्ड हिम कि हम रिमूव लेंस कर दें और आरएलई करके और उसका दूसरा लेंस डाल दें. एंड वी डिड दैट, एंड आफ्टर दैट ही डेवलप्ड दिस प्रॉब्लम. तो ये सिमिलर वो कंडीशन थी. फिर इसको डीमैक किया और ही इज नाउ फाइन. In one eye. He was only eye patient. He was one-eyed. The other eye had already lost because of multiple surgeries. Chale.
So now let's shift it. Thank you. Achha, now we're sort of shifting on to a discussion type of thing. So for the panelists, what do you prefer and why, microkeratome versus femtoLASIK? So we've heard this debate for a long time now. So what is the difference?
It's not about the preference, it's about the charge, the cost of the
femtoLASIK. So if let's say you had equal charges, let's say दोनों का charge में कोई फर्क नहीं है, what will you go?
Femto.
Why?
Because of the flap thickness, एक बहुत uniform flap thickness होती है femto में. It's very precise. The measurement you take, whether high K ratings, whether low K ratings, it gives you the same 9mm flap. So that's why I will definitely go for femto. If the price is same, but if because of the difference, definitely patient की preference होती है. I don't go for microkeratome if the central corneal thickness is less than 510. Thinner corneas में thin flaps बनेंगे, and that can cause flap related complications. So I avoid, and मेरा यही advice है कि microkeratome should not be used in less than 510 microns. अगर cost का issue होता है, it's better to go for PRK rather than using microkeratome in these cases. High K readings है, for example, more than 47. then there are high chances of having buttonhole. तो वो भी microkeratome में ज़्यादा problem कर सकता है आपका. तो it's better to go for femtoLASIK या PRK in these kind of cases. Flat K readings है, less than 40 है, उसमें free flap हो जाएगा. If you use microkeratome, it's better go for PRK either अगर price का issue है, or go for femto. मेरी कुछ ये limitations है.
I think अगर everything is okay, if the patient have no issue with the money, I think go for the femto. It's more safer, more precise. And other thing in keratome, there are some problems, flap related, and the patient is more atypical personality. I think it's not fit for the keratome. So it's better to go for the femto if everything is okay. And there is no any financial problem. I think it's a better choice for the femto.
One observation, I'm using microkeratome since last 22 years. And I'm also using, I'm comfortable with both. I'll go for femtoLASIK only. जो डॉक्टर असफर ने क्या जो लिस्ट बताई वो सारी लिस्ट की में से एक मेरी ऑब्जर्वेशन वो ये है कि I have never seen flap inversion in femtoLASIK.
Absolutely.
जो आप microkeratome में बहुत मर्तबा देखते हैं.
So what he's talking about is flap inversion on the very next day. So the flap sort of flips in on itself.
Yes.
On the very next day. just for the audio. Sure.
I've not done as much as Dr. Hashmani, but I've done quite a lot of femto and LASIK. Flap complication अभी तक जिसके साथ भी मेरी हुई है वो माइक्रोकेराटोम के साथ हुई है. Either displaced हो या even with the excessive blinking or squeezing eye, that flap actually lifts. Or even अभी recent एक case था जो मैंने refer किया था, that man had a habit of very tightly squeezing eye, and he actually admitted that later on. He had a displaced flap which I had to manage twice, और एक को तो मुझे stitch करना पड़ा. Femto के साथ मेरी कोई नहीं problem हुआ. और I prefer femto. I actually give this choice to the patient, affordability or non-affordability. मैं तो ये कहता हूँ कि we don't operate intracapsular cataract extraction nowadays because things have evolved and we want to progress. And progress is that do femto, which is much safer. Handling the flap is much better, and I'm sure the results are better. Money wise, yes, you can always adjust. I mean, जितना भी आप कर सकते हैं, कोई fixed money नहीं है. That should be the secondary thinking about financial things. लेकिन मुझे अगर choice दी जाएगी, I'll always give the choice कि मुझे femto करना.
Because अभी हमने last में एक case किया था with the keratome. So उसको हमने bandage contact lenses over दिए. After the 3 days he comes with the decreased vision, and I saw there is a flip up and rolling up. So this is the problem. Sometimes the patient is not too much caring. So I think femto is the better choice if there is no any issue.
There are two more things. There are chances of displaced flap, as Dr. Hashmani and Dr. Israr said. Then there can be chances of impurities with microkeratome, and then there can be some mechanical issues as well at the time. The most important thing is, and their microbial keratitis chances, they are very low with femto. So these are the things that definitely femto would be always the first preferred choice. And as Dr. Tanvi said, that for the charges, why we can, especially in those cases when you are in doubt, you should go for femto, especially in flatter case, definitely.
Thank you.
Even जब आप marking करते हैं for the keratome, पेशेंट लिटिल बिट भी आपकी आईज जैसे ही आप उसको रखते हैं, उनको कोई चीज़ जैसे ही नज़र आती है, इज ब्लिंकिंग आप मूविंग, तो आपके इपीथियल जो प्रॉब्लम्स होते हैं वो भी माइक्रो मार्किंग की वजह से जाए. इन फेमटो यू हैव द कस्टमाइज एवरीथिंग, फ्लैप एवरीथिंग, सो इट्स बेटर टू गो फॉर द फेमटो.
So let's move on now. Sorry.
Keratome.
I've seen microstria in any of my patients because your flaps it very nicely in the neck and does very well. So you are very पिछले 5 साल से patient आता है, मैं कहता हूँ हमारे पास का ऑपरेशन नहीं है, मैंने उससे कराओ, अगर femto कराना है तो मुझसे कराओ.
So you are a very skillful refractive surgeon then.
Well, you know,
Mashallah.
So the message is not कि femto का अगर flap होगा तो उसमें कोई complication नहीं होगी. I have seen complications of femto flap as well. So it's not the message, but as compared to microkeratome, femto के जो flaps हैं, they are much precise, much safer. अब इसीलिए the technology is moving forward. Flapless smile की जो बात करते हैं, जिसमें flap ही नहीं है. सही, ये रिंकलिंग का मसला ही नहीं आया, आपको एपिथेलियम लूज का इशू ही नहीं हो, आपको डेब्रिस का इशू ही नहीं हो. सो स्माइल की तरफ जो जा रहे हैं वो इसी वजह से जा रहे हैं. सो वो उसकी बात बाद में होगी. चले,
let's move on. So what parameters do you consider before LASIK or smile or whatever it is? What do you consider, for example, PTA अगर है तो what do you consider in these patients? How do you calculate PTA? Do you consider PTA? Do you consider the K readings? So any one of the panelists would like to comment on this. So for example, if you've got a patient that is -8 and he's got a K reading of 40, would you consider the K reading or would you ablate the complete 8 considering that the thickness
definitely -8 अपने number निकालना and you have a K reading of 40. All we are going to do is just to ablate the cornea. 40 पे से आप निकालें 0.8 से multiply करें, so that will end up in 32 or 34, and that can lead to a flat cornea. तो हो सकता है आपका number तो उतर जाए, लेकिन patient की quality of vision इतनी मजे की नहीं होगी. Even if you optimized it, even if you customized it, पेशेंट की क्वालिटी ऑफ विजन अच्छी नहीं होगी. ही माइट और शी माइट कंप्लेन कि आई एम नॉट एबल टू सी क्लियरली, मुझे नज़र आ रहा है लेकिन मैं फोकस नहीं कर पा रहा हूँ बिकॉज ऑफ द फ्लैटनेस ऑफ द कॉर्निया. सो डेफिनेटली टेक इनटू कंसिडरेशन द के रीडिंग्स. इन हाइपरोप में भी यही इशू है. इफ़ यू आर यूजिंग चूजिंग अ पेशेंट विथ 48 के रीडिंग्स है एंड यू वांट टू इंक्रीज इट लाइक +5 नंबर उतारना है, तो यू आर गोइंग टू इंक्रीज अ लॉट ऑफ के रीडिंग्स. तो उसकी जो क्वालिटी ऑफ विजन है, अगेन इट्स नॉट गोइंग टू बी वेरी गुड. सो डेफिनेटली के रीडिंग्स शुड बी टेकन इनटू कंसिडरेशन बिफोर टेकिंग ऑफ दीज थिंग्स.
Anyone else want to comment? So
tell them that, look, I'm going to reduce your number to this extent and you will have remaining number, or go for something else, go for ICL or something.
excellent point. So always remember that when we were doing LASIK 20 years ago, our main concern was lower order aberrations. So we wanted the numbers to go back from -8, -5, -3, whatever it was, to 0. Today we don't have to think about it because our machines are incredible. If your refraction is good, you will get to 0. Now the concern is quality of vision. So now we're talking about something called higher order aberrations. So if you have a very flat cornea, you're going to have a very sort of high spherical aberration, which will cause him, number 1, glare, number 2, night myopia, number 3, night vision problems. He's going to have trefoils, he's going to have spreading of light. So that is very important. So it's not just in flat corneas. This thing can happen in normal people as well. So what the pupil size along with the internal sort of aberration is very important in a lot of cases. But yes, flat cornea is one of sort of the basic things that you should know. PTA. How many of you look at PTA?
Can I ask one thing from Dr. Hashmani? That what is your preferred lower limit, 34 or 36?
36.
36.
36. And one diopter reduces 0.9. That's what I consider as. Don't go below that.
Below that. Thank you.
And residual stroma should be not less than 300. This
300.
is a default. अच्छा, जो thickness ablation में consider definitely करते हैं कि it should not be more than 40%. तो वो कैलकुलेट आप करते ही हैं, जैसे कॉर्नियल फ्लैप प्लस द एब्लेशन और उसको परसेंटेज रेजिडुअल स्ट्रोमा से आप परसेंटेज निकालते हैं, और 40% से ज़्यादा नहीं होनी चाहिए. इसी तरह स्माइल में द लेंटिक्यूल साइज और जो आप जो कैप छोड़ते हैं उसको और रेजिडुअल स्ट्रोमा से वो करके 28% से ज़्यादा नहीं होना चाहिए. तो ये दोनों चीज़ें तो बहुत ज़रूरी हैं जो हम करते हैं. बट फिर आपने कंफ्यूज किया था नुमान मुझे कि पीटीए जो है वो उसकी कोई वैल्यू नहीं है, वो कोई बहुत ज़्यादा स्टडीज़ नहीं है उस पर. तो
मैंने ये नहीं बोला कि उसकी वैल्यू नहीं है, बिकॉज आई पर्सनली यूज पीटीए एज वेल. आई थिंक इट्स अ वेरी गुड सॉर्ट ऑफ थिंग. बट पीटीए जो है, देयर इज ओनली वन स्टडी दैट वाज पब्लिश्ड बाय अ डॉक्टर इन ब्राजील. आई डोंट रिमेंबर हिज नेम.
माइकल बेलन.
नहीं, बेलन की नहीं थी.
माइकल बेलन.
नहीं, बेलन डिड अनदर स्टडी, बट इसकी ओरिजिनल स्टडी किसी और ने की थी. सो दिस पर्सन सॉर्ट ऑफ शोड दैट एनी टाइम you have ablations over 40%, you're going to have an increased risk of ectasia. However, that's only one study, it hasn't been corroborated, nobody else has been able to prove it, so that's the only sort of
the thing is that
but I use PTA.
I don't use PTA because ये जब हम शुरू में स्टार्ट किया था 10 years back, तो उस वक्त टोपोग्राफी होती थी. वी हैव टोपोग्राफी, बेलन एम्ब्रोजियो, हम उस पर डिसाइड करते थे. देन माइकल बेलन इंट्रोड्यूस दिस टर्म. हम किसी कॉन्फ्रेंस में गए थे and he introduced this thing PTA. तो हमने we take into consideration भाई 40% होना चाहिए. One of my patient developed ectasia with a normal corneal topography with 40% of PTA and everything. तो उसके बाद से I'm put more emphasis on residual stromal bed. I don't take into consideration this percentage thickness ablation anymore right now.
Are you aware of any long-term study of this residual bed?
No.
क्योंकि ये हम लोग कहते तो हैं कि रेजिडुअल बेड इतना होना चाहिए. Is it safe? Is there any evidence for that, or is it just?
So the residual bed is very sort of interesting sort of thing. That's a very good point. So when LASIK started, they sort of kept making things thinner up to 250 microns. Then nobody sort of had the guts to go below that. So you're right, there's no sort of long-term studies because nobody has the guts. So 250, the official recommendation to 250 hai. We don't go below 300. True. But 250 se niche koi bhi nahi gaya and we don't know what will happen after that.
It's just that I'm aware of someone who was doing the study and the company actually stopped it because the data was against the refractive surgery. Any paper or any evidence that comes against the refractive surgery, that doesn't get supported by the companies. So these evidences, they don't come out actually.
You're absolutely right. So this is a big problem in research, especially those that are funded by Big Pharma, that this type of thing does happen. I mean, if they're going to be funding the research, they're not going to let it come out.
आप स्टडी करें ना कि 200 बेड अच्छा होता है तो आपको फंडिंग मिल जाएगी, लेकिन मैं स्टडी करूँ अच्छा नहीं होता तो मुझे नहीं मिलेगी.
Absolutely, and that's why we don't go below 300. हमें और उसका concept क्या है? You have to understand why I think of PTA as a very good tool and why I think of RSB as 300. So you have to understand the biomechanics of the cornea. Cornea के biomechanics क्या बोल रहे हैं आपको? Cornea is not one sort of piece of plastic जिसमें आप जितना निकाल सकते हो निकालो. Cornea का जो actual जो biomechanics है, that's actually being supported by the anterior 1/3 of the cornea. So almost 70 to 80% of it is in the anterior 1/3 and the rest of it is in the posterior 1 to 2/3. So when you do a lot of ablation and you go beyond the PTA, you are sort of removing that entire 1/3 of the cornea and you're removing the entire place that's actually supporting the cornea. And that's why the PTA for me is very important. Obviously it's more theoretical than anything. But, and then this was also seen in SMILE studies where the expert in biomechanics right now is Cynthia Roberts, who's actually shown this very well, that when you do LASIK, you basically shift the entire biomechanical profile to the posterior of the cornea. Now, if you have enough posterior cornea, you're not going to develop ectasia. In SMILE, what happens is the physiological sort of anterior and posterior corneal biomechanics, they remain intact, and therefore the risk of ectasia then becomes theoretically lower in SMILE. उसमें भी ectasia तो होता ही है because we don't obviously understand everything, but the biomechanics are far better in SMILE.
Also, there is one problem with the maximum ablation is above not more than 100 micron से अगर ज़्यादा करते हैं तो there is also chances of ectasia. This is also risk factor for the ectasia. If you have the too much myopia and you want to do the ablation, I think the 100 is the maximum. If you go beyond the 100, there is a chances in future maybe patient will develop with the ataxia or the keratoconus.
Excellent point. Excellent point. Okay, so now I'm going to move forward. So we have, if anyone's following the USP group, we have recently launched Smile Pro in Hashmanis Group of Hospitals. And just 2 weeks ago, we did our first surgeries and we've had very good results with them. Just wanted to show you what the surgery actually looks like. So this is sort of so this is in real time, this particular part. It's the femto making this sort of the smile lenticule. So this is in real time. So within about 10 to 15 seconds, you've got the lenticule made. And then you've got sort of two ways of doing it, with and without forceps. This is sped up, I think, with in 2x mode. And we dissect the anterior sort of part of the lenticule. Then we go to the posterior part of the lenticule. And then जो भी sort of residual है, हम forceps से जाके उसको detach करके निकाल देते हैं, and then we iron just like we do with LASIK. And we see that the lenticule, so right now we're checking if the lenticule is sort of circular, if you've not left anything inside. And then the second sort of is without forceps. Again, this is in 2x mode. Again, going anteriorly, then going posteriorly. And then if you're successful in detaching it almost 360 degrees, you can take this out simply by the spatula and you don't have to put the forceps in. So this is the two ways of doing smile surgery. Inshallah, we'll be sharing more cases with you as we start doing more of the cases. So Now the discussion, we've sort of touched on it already, but Smile Pro versus LASIK. Even if you're not doing it, obviously, what do you think are the advantages or disadvantages of either surgery? Panelists or anyone in the audience wants to chime in. We would love to hear it.
LASIK has been here for last 20 years. Smile Pro has been there like for last 10 years. So data for LASIK is quite much more than Smile Pro. Smile Pro is good, I like it. Lekin we need to wait and see what are the long-term complications that can happen, and then we can compare it with this. Right now, I prefer LASIK more because it's easy. For me, it's more easy to do. Smile Pro में भी कोई issue नहीं है, लेकिन कोई such advantage जो कि Smile Pro बताता है वो समझ में नहीं आ रहा है. For example, अभी आपने बात की कि इंटीरियर कॉर्नियल जो होती है उसमें सबसे ज़्यादा हमारे पास होती है टेंसाइल स्ट्रेंथ ऑफ द कॉर्निया, बायोमैकेनिकल स्ट्रेंथ, ठीक है. But if you look at the data, those patients who had PRK में तो हम सिर्फ इंटीरियर उड़ाते हैं ना, has the least number of ectasia.
Sir, nobody has
this
said
is what I'm saying.
PRK has the best biomechanical strength. Bar any of the surgeries.
The thing is that we ablate the interior surface.
No. So let me explain this to you. So, with LASIK, you're removing 120 microns or 110, whatever you're doing, or 180 or 150, जो भी आपका फ्लैप है, and then you ablate. So, LASIK में जो 120, 130, 104, जो भी आपने किया है, that has no biomechanical effect on the cornea now. It's a dead tissue, basically. So, that's why LASIK last पे आता है. Number one पे PRK है. Absolutely, there's no question about it because yes, you're ablating the anterior.
Let's move forward. LASIK में हमने फ्लैप बनाया, we are not removing, ठीक है. अब come back to the Smile Pro. We are not talking about PRK, ठीक है. Smile Pro में, if you look at the picture, if you look at the video, we cut the cornea. फ्लैप नहीं बन रहा, लेकिन 9 mm, 8 mm कट हम बना रहे हैं. We are doing the same thing. I mean, removing the lenticule. So we are also weakening it. That's why we are seeing ectasia with Smile Pro as well. So if you say कि Smile Pro में ectasia नहीं है, LASIK में है, no, it's not this. ठीक है. बाकी yes, Smile Pro में आपका fast है. You remove it. You don't need excimer laser. You just need a single laser. एक ही laser से सारा काम हो जाता है. You don't have to have a excimer laser. Cost उसकी थोड़ी कम पड़ जाएगी आपको. Patient के लिए benefit हो जाएगा. You don't have to use microkeratome for that. ठीक है. But then if you look at the Smile Pro and compare it with LASIK में you can customize. You can do contour vision. You can actually ablate. You can improve the interior corneal surface. Smile Pro में right now it's not here. With astigmatism, somebody comes with pure astigmatism. You can remove it with LASIK, but with the Smile Pro, there is a limitation for this. So these are the things. Yes, it's a good thing. Let's say कि थोड़ा सा आगे बढ़ते हैं तो फिर देखते हैं कैसे. लेकिन अभी तक LASIK का सच.
There are a lot of things I agree with you on because मैं तो, as Abu also said, that I wasn't in favor of buying the Smile Pro, but sir wants to say something and then
होनी तो चाहिए भाई हमारे पास.
पहले
just one. जी.
वो मैं बताता हूँ. I will tell you everything that my points were. I will tell you.
अच्छा, ये डॉक्टर जो हमारे असफर की बात बिल्कुल सही है. बहुत सी बातें इनकी सही है बिल्कुल. This is how the things are looked at. जब हम इंट्रा कैप्सुलर, एक्स्ट्रा कैप्सुलर, और जब अभी आपके ज़माने की बात है कि एक्स्ट्रा कैप्सुलर जब सर्जरी करते थे और फिर फेको आया, तो हम भी यही करते थे कि यार बाहर बैठो, अभी हम फेको एक्स्ट्रा कैप्सुलर जल्दी कर लेंगे. तो दिस इज़ व्हाट द स्टेट ऑफ डिनायल वाला जो मतलब एक्सेप्टेंस जो है वो जल्दी नहीं होती. दिस इज़ व्हाट द मोस्ट ऑफ द सर्जन्स आर थिंकिंग ऑफ. लेकिन तीन चीज़ें जो अच्छी हैं, जो नई चीज़ आई है वो टेस्टेड है ना. ऐसी बात नहीं है कि अभी कल ही आई है और आज आपने शो शुरू कर दिया. तीन चीज़ें जो बड़ी अच्छी हैं इसकी, जो आप देख रहे हैं, जो प्रॉब्लम है कि जितनी कॉर्नियल नर्व्स हैं रेडियली जो आपकी आती हैं कॉर्निया के अंदर, वो सारी आप जो फ्लैप बनाकर आप काट देते हैं. फिर जो सेंटर में जो बचा सब बेजल प्लेक्सस, उसको भी आपने एब्लेट करके उड़ा दिया. तो ड्राइनेस जो होती है तो बहुत ही बड़ा प्रॉब्लम है उसका. नंबर 1 फ्लैप रिलेटेड कॉम्प्लिकेशन सबसे ज़्यादा है. और फिर नंबर 3 आपकी बायोमैकेनिक्स जो है वो आप बायोमैकेनिकली वीक करते हैं कॉर्निया को, जो आपको नोमान ने बताया अभी कि एंटीरियर 130 जो कॉर्निया का जो स्ट्रॉन्गेस्ट पार्ट है. स्माइल प्रो में कोई चीज़ है ही नहीं. आप जो कॉर्निया कट करते हैं, जो आप करते हैं सेंटर जो फ्लैप निकालते हैं, और उसके जो रेडियल जो नर्व्स गई हैं वो तो बिल्कुल इंटैक्ट हैं. तो जो ड्राइनेस का जो फैक्टर है इज मच लेस एज कम्पेयर टू दिस, एक्टेजिया मच लेस एज कम्पेयर टू दिस। लेकिन अगर हम और तीसरा क्या मैंने कहा, फ्लैप तो है ही नहीं इसमें, फ्लैप कॉम्प्लिकेशंस का सवाल ही नहीं है। तो स्माइल प्रो इज़ द वे फॉरवर्ड और फ्यूचर यही है जो रहेगा। तो नई चीज़ें जब आती हैं तो इसी तरह प्रो एंड अगेंस्ट बहस होती है। जी सर। हाँ, वो ओपीएल पे हम बात करेंगे।
There was
Glare and other things also less.
एक सेकेंड। Yes.
How?
Does it hold true for cataract?
I would
Femtocataract.
No,
अच्छा,
please.
femtocataract भी मैं I am pro to femtocataract. Since I am,
but my
लेकिन
point
problem
is-
Let's
problem
please
ये है
keep
कि
the
the
discussion
cost.
on point. Let's please keep the discussion. You can have the femtocataract discussion later, please. And I will be part of it as much as Abu will, no worries. But please, let's keep it on smile. We're not talking about cataract at the moment. Sir wanted to say something.
Just
Sir.
one thing, it was said that there's not much data about the Smile Pro. Smile Pro कोई बिल्कुल अलग चीज़ नहीं है। जैसे एक्स्ट्रा कैप से फेको आया था तो देयर वाज नो डेटा ऑन द फेको। ये तो ऑलरेडी वी आर बीइंग डूइंग इट फॉर लास्ट 20 years। तो इसको पर इतना कोई डेटे की ज़रूरत नहीं है, बस वी कैन जस्ट डिस्कस द प्रोज एंड कॉन्स।
Absolutely. So the data for Smile has been being done for the last 10, 12 years also. So I mean, Smile Pro is just a faster version.
इसका एक कौन ये भी है कि we for touch-up surgeries with Smile it will be very difficult for touch-ups. But while doing femto or even with microkeratome, the touch-ups are easy. As I agree with Asfar कि there are some points like biomechanical stability की जो बात है वो it's overhyped I think, क्योंकि still we are creating two flaps. So we are not creating the flap but we are ablating it. So we are thinning it at least. So there are few points which are in favor and few points which are against. I think this will be a valuable tool for few cases, definitely.
So absolutely, I agree with all of you.
We'll be doing what is on the TikTok actually nowadays.
So I'm just going to give a few brief comments. Sir, Dr. Idris wanted to say something.
Well, very interesting discussion, but I'm thinking Smile versus LASIK from the vitreoretinal point of view. In LASIK, as such, the microkeratome and the femto-LASIK, if we apply a suction force on the eye, and in LASIK we are in the range of maybe more than 65 millimeter of mercury for a short period of time. In femto, less of a pressure but more of a duration. Then we do the procedure and then release. So the dynamics of the pressure changes in the eye, along with the wave, the shock waves of the laser that we apply. All of these are making changes into the vitreous and causes changes in the vitreous to the extent of causing posterior vitreous detachment. If there are pre-existing lesions in the retina, which we can talk later on or may become the part of the discussion, which have been looked after or not looked after, whatever the changes are, I think the biggest advantage that I see, I don't have the experience of doing Smile and just for the first time. The biggest advantage is that we are not doing anything to the dynamics of the vitreous, and we are not inciting any insult to the posterior segment. I think this could be a big advantage. I do not have any scientific evidence to corroborate what I say, but maybe time will prove, with more and more Smile coming into practice versus LASIK and femto-LASIK, that the posterior segment problems could be less in Smile versus LASIK and femtolacin?
Absolutely, this is a valid point.
So yeah, so I think there was a very healthy discussion with Smile Pro versus LASIK. Let's move on before we sort of take the entire session through it. Acha, now the next sort of point is, and we would love your opinion on all of these cases as well, is that we're doing LASIK surgery, we're doing smile surgery or whatever you're doing, and then we look at the posterior surface and we see all sort of kinds of lesions. And this is to highlight how important it is to look at the posterior surface and to see if you need to intervene before you do LASIK surgery or whether we do need to intervene. So this is a 37-year-old female. I'll show you both of the eyes before I'll show you one eye and then we'll go to the other eye. So this is the case. We're seeing an optos image. If you can see here, you can see a hole inferiorly with subretinal fluid. For those on the other side, there it is. What would you do in this case? First panelists, and then I would like the retina specialist to also reply. What would you do in this particular case?
I would like to do some more argon laser. If you can see, I think inferiorly.
So this has not been laser. It's not laser.
This is a pigmented scars.
Yeah.
Okay, this is not laser.
And circulatory laser?
नहीं है.
Okay. Definitely फिर तो laser पहले करेंगे.
Okay. Laser, sir, if
I think
if
it's
you would
better
like to
not 360 needed, only the circle with the hole, and then after that you will go for the surgery.
What is the refractive error?
-9 in the right eye and -6.5 in the left.
Is it necessary to go for the laser?
That's what I want to know.
No, इस laser की बात नहीं कर रहा हूँ. Refractive laser की बात कर रहा हूँ.
So I will tell you what we did, and then.
Are we planning smile or we are planning?
So this is pre-smile. We only had LASIK.
It's a pre-smile. Now, look at the pigmentation. That is, you said there was a pocket of subretinal fluid.
Yeah. So let me show you the beauty of optos. I think इसमें सही नजर नहीं आ रहा है, but if you can see, it's lifted from here and from here, and then there is sort of this vitreous traction coming from here. हाँ, इसमें नजर नहीं आ रहा है. I'll show you the next case. उसमें आपको नजर आ जाएगा. So ये देख लें. So this is the other case. This hole is here, and then once we get to the OCT, this is the OCT. So now what would you do in this case? This is a much better OCT.
The first slide that if you just remove that.
ये वही patient. This is the other eye. This is the other eye.
If I look at the pigmentation, as he rightly pointed out, that a laser has been done here, and we will do additional laser. The response of the nature to this pathology, the pigmentation itself says that nature is looking after the spread of the SRF, and if it remains there without doing anything to this retina, this is very, very unlikely to detach unless there is excessive force of the detached posterior vitreous that can pull it out. I would safely let this patient go without any further intervention, because the more laser I do, the more inflammation I will induce, and more traction on the vitreous that is pulling. So if it was left to me, I would let this patient be like this without doing any intervention and proceed with the LASIK, whatever it is.
And what about this eye, the other eye? So this doesn't have any sort of the.
Is this the
OCT, right? Yeah.
If this is operculum, I would definitely go for the laser prior to doing any intervention for the refractive surgery. If there is no pigmentation around the hole, then I will induce a barrage around the retinal braid. Yeah, we will do it. We will do the organ here. If the the operculum that you see itself is an evidence that the vitreous is detached in this area. And if there is no pigmentation around the break, I would induce a barrage around it, in this case, not in the other eye.
Okay, and if you were going for so first of all, would you go for LASIK in these cases?
I would go for LASIK after
the barrage?
After the barrage,
and
yes.
you would do LASIK without doing barrage in the other eye?
In the other eye, yes.
And after how many days of barrage?
The evidence is 7 days. 7 days to 2 weeks. 2 weeks, if you look into the literature, there is more evidence to wait for 2 weeks, and you can do any procedure for the refractive surgery after argon laser and the barrage laser in the retina. 7 days to 2 weeks.
And certainly Smile Pro.
Smile Pro,
preferably.
as I said initially, there are no dynamic changes into the vitreous in the smile that we described and that we know. So in that case, if Smile is available, I would go for Smile rather than the LASIK or the femto-LASIK.
Okay. So, and
Noman, can I say something? Here.
Sure. I don't know.
So agree with Professor Idris. Only the thing is that in our first case, of course, like there is the pigmentation, but there is the vitreous attachment as well.
Yeah.
But I also saw this OCT, and if you see, there is the traction only in the one margin, and there is the pigmentation. So my question with Professor Idris, so because there is the traction, pigmentation also there, but if you see detailed OCT, there is the operculum as well. So what do you think? So we should leave, or even though the LASIK, or we should proceed? Because there is the operculum. Because in this OCT, we are unable to find out. The first eye. Second, of course, definitely we need to go for the laser. Yeah. But first, I'm talking about this. There is the pigmentation.
I will induce more inflammation and more traction into the vitreous, and there will be more chances of the posterior vitreous detachment causing the problems in the other areas as well as in this area. So in this case, my tendency would be not to do anything and leave it as such and proceed with the LASIK procedure, preferably Smile. This will be my tendency.
Okay, thank you.
No, Smile has a lower right.
No, Smile has number two. The Smile, this femto, we are docking, we are putting scleral pressure, and here we are just docking on the cornea. The pressure is much less.
There is a rise, absolutely. I think it's about 25 to 30. So ये 20-25
much less than microkeratom 64 with the 25 with the femto-LASIK, and in this about 18-20. So it is much less, and this is corneal pressure. That thing is scleral pressure. So this will affect retina or posterior segment much less than your microkeratom or femto-LASIK.
So the other reason, sorry, just let me put this question and then. Sir, no, sir. So the other question that I have, because we didn't go into that detailed discussion on that, which I was expecting, was that especially in this city, there is this sort of tendency to, if you've seen anything, they're going to do a complete 360 laser instead of just doing. So we're talking right now about barrage laser going around. But the tendency in Karachi now is that there is a complete P360 laser of whatever chota sa hole nazar aaya sometimes without that, there's a complete 360 laser. So I want to know from, obviously, the experts that are sitting here, ye appropriate hai ki nahi hai, and that's the message I want. That's why these slides are here.
So may I take the liberty of now,
Sir,
answering your second question as well? And I know I'm sitting beside Professor Idris Hedi, but I'm trying to gather courage to disagree with him on the first patient with the atrophic, what I feel like is an atrophic hole with subretinal fluid. Nature is looking after that. But we live here in Karachi where there is hardly any emergency services. And this patient has maybe 15, 20 years to go before, the vitreous detaches. And, we all see a lot of patients, young patients with atrophic hole, with detachments, with very well attached vitreous. So I would be, comfortable in lasering it, albeit gently. You don't want to be too aggressive with the laser. So my take on both eyes would be to do laser, whether before LASIK or not LASIK, if I see this patient. But in our practice, we see a lot of patients, just high myope, as it is, without any without any plans for LASIK or pre-cataract surgery, 360-degree laser, then you'll be comfortable. No, I think this should not be practiced, because these patients, they're going to go into posterior detachment anyway, with or without laser. So if with laser, we all have seen a lot of cases with irregular breaks, multiple breaks after these 360-degree lasers. And 360-degree lasers, the only indication in literature and in practice is, second eye of GRD, syndromic cases of retinal detachment. This is where you do 360-degree lasers, and 360-degree laser is not an easy task. The 360-degree lasers which we see clinically coming across from the city, this is hardly any 360-degree. You see patchy few lasers here and there, and I'm quoting here John Scott, who used to believe that if you want to do a 360-degree prophylaxis, you have to do 360-degree cryo, because you cannot do a good 360-degree laser. Now I disagree here now, because you can manage a good 360-degree laser if you do. I did one yesterday, and I'm going to do one next week. Second eye of syndromic patient. So this is my take on this. I'm sorry to take a lot of time.
No problem. So what we did was I sort of am very careful in these sort of patients. So we did a barrage laser on the first and second eye. But of course, I will take the point home that if there is pigmentation, then maybe we can observe them. And then in the other eye as well, so you can still see the vitreous traction in the other eye. This is a much better OCT. And then even in the other eye, we did a barrage. So the point of this, we went in a completely separate discussion to what I was expecting. But the point was that do barrage laser, that's much better. Please, we need to stop doing the P360 complete 360 encircling that we keep doing and sending over. So, yeah. Sorry, yeah. So the question is, how many rows of lasers do we need to do in these cases?
Well, we're talking about doing the barrage laser, 2 to 3 rows. 3 rows would be enough. I just take this opportunity to further comment on the barrage laser versus the tendency to do 360-degree laser. This is not indicated here. Just treat the pathology, because laser itself would cause problem. I have seen giant retinal tears after 360-degree laser.
Decision to do laser in such cases, if the patient is symptomatic?
If the patient is symptomatic, we need to see what the problem is. The problem is it plain posterior vitreous detachment that is causing the floaters, and the bumping of the vitreous on the retina causes the flash. If that is the case, we do not do anything, any intervention.
The same scenario, like it's a break and it has pigmentation around it, or a peripheral little degeneration, and the patient is symptomatic.
The presence of the degenerative spot in the retina with holes and symptoms is a definite indication for the laser. Now, how much laser to do? My tendency would be to do the laser around the pathology only rather than 360 degree in that patient which you're talking about. If you are having multiple patches of lattice, then you could go for the 360 degree, but localized areas, the patches of the lattice or the snail track degeneration or the isolated breaks, if they are localized, then go for the localized photocoagulation rather than 360 degree.
So let me show another case now. So this is sort of the beauty of Optos Silverstone, where you can do an OCT and sort of evaluate the periphery, which we couldn't previously. So like we said, we did barrage laser in both of them. All right, so case 2, another consultant saw this patient and it was labeled that there is some atrophic patch on the retina. Can you please evaluate this patient? So this was a 21-year-old, came to us for, again, refractive surgery because we are a refractive center. And this is sort of the Optos image. Now you can see a little bit of some sort of irregularity here. But if you see, and we sort of do an OCT through that irregularity, you're not seeing much through it. But when we found another patch on this same retina, so I'll go to the first image. If you see on the top, right there, here, you see, you can't see it on these monitors, but in that top zone, we see this. So there's no hole, but there is a traction sort of pulling the retina. There is a SRF. What would you do now?
This is a very interesting scenario. If we are going to do the refractive procedure, in this case with the technique of the LASIK and the femto-LASIK, then you are inducing more dynamic changes into the vitreous because of pressure. I would put the barrage laser around the area of the lattice that we saw, and the area which is thin, and around this area as well, because this is going to get pulled out during the process of the LASIK or the femto-LASIK. Maybe not with the SMILE. If I do the SMILE procedure, probably I will not do anything to this procedure because we are not producing the fluid or vitreous dynamic changes. But certainly for the LASIK and the femto-LASIK, I would put the barrage laser, not 360 degree.
Yeah, absolutely. So,
Noman, just a little comment. This patient and previous patient, both have got retinal problems, both have got the vitreous pulling. Is it really necessary to go for refractive surgery?
So let me just answer what we did in these cases, and then Sir can answer as well. We still haven't done surgery on either of these cases. They're under observation. And so for me, if in the next year I don't see a change, then we'll go for surgery.
But if there's no change in the next 12 months, when you do the LASIK or SMILE, the pulling of the vitreous, as Dr. Sahib has mentioned, it will again induce a new
Absolutely,
change.
and in theory that can happen, but my inclination is in the year, if it hasn't sort of changed, that configuration hasn't changed due to the it's very unlikely that after doing that laser that it's going to detach. That's my thinking, but.
Yes, the answer to your question is whether the person should go for the LASIK surgery or for refractive surgery or not. Look, 7 to 8% of the normal population has got the lattice. Myopic, about 26% to 30% would show the lattice degeneration. Now, anybody with myopia, obviously we do this surgery mostly in the myopic patients, young patients, they should know and they should be discussed with. We should be discussing with them that they are having more risk of retinal pathology as compared to normal population anyway. They must know that even without LASIK, they are going to have more risk of having a retinal problem as compared to the normal population. But this LASIK procedure may or may not be contributing to the retinal pathology they will be having in future. So they should know they are heading for added risk of having retinal problem even without refractive surgery or with refractive surgery. They should be aware that this point was discussed.
Should we use the words may or may not, or should we use the words it will increase the risks?
There is no scientific evidence as such for the LASIK or the femto-LASIK as a risk factor if you look into the literature. But the dynamic changes, I mean the long-term results and the long-term studies would show what actually is the contribution by this invasive procedure that we do into these eyes. But they should know that this could be a risk factor in future, but they are at the risk of having this problem anyway because of the existing pathology.
So Dr. Idris, my question, since we are dealing mostly with the high myope patients, so and mostly the high myope we implant phakic lenses, ICL or Artiflex. So would you recommend in these patients phakic lenses or ICL? Recommend, or should we go for LASIK or SMILE only?
As I understand, any intervention into the eye that you do, either by inducing the force that you are applying in the LASIK and the femto-LASIK, or you do intervention in the form of going inside the eye when you do the ICL or do refractive surgeries, going inside the eye, you are increasing the risk of posterior vitreous detachment. The posterior vitreous detachment has been seen just 2 days after LASIK procedure, and 86% of the eyes who undergo LASIK and femto-LASIK have evidence of the posterior vitreous detachment. The evidence has not that been strong with the ICL and the procedure like that, but certainly going inside the eye, you are inviting for posterior vitreous detachment, and it is the posterior vitreous detachment that initiates the problem in the existing pathology which is present in the retina. So you are increasing the chance of PVD, posterior vitreous detachment, and associated retinal detachment by any intervention at all. So if you go in for the phakic lenses in these kind of pathologies, you must explain to the patient very clearly that even otherwise, though you have more chances of retinal detachment, this procedure adds to the list of the risks that you already have for having future retinal detachments or retinal pathology.
So keeping in view the same discussion, thank you for starting it. If you can read the question on the screen. So we've all seen now RLE being done in very young patients, 15 years, 16 years, 22 years, 30 years. So for the panelists and for you as well and for you, how do you view refractive lens exchange in those that are under 40? Because obviously the people that we're doing are either high hyperopes or high myopes that we're doing refractive lens exchange. And it's being done very commonly in the city. Do you view this as a problem or not?
The new recommendation is, I think, not to do any refractive laser exchange under 40. I think that recommendation is from some cataract and refractive surgery platform. European platform.
So there was a, so I would let them comment and then we can go for it.
I mean, my personal view about high myope is, I don't recommend. But for high hypermetrop, it's a game changer for them. It really changes their life. When like early cataract surgery is practiced in this part of the world, I think more than it should be. And I've done early cataract surgery in age 50, 55, just because of the refractive reason. And that is a game changer for them because high hypermetrop, they have problem with the distance.
So you're saying in 50, 55. I'm talking
Yeah,
about
I mean,
20-year-old.
pre-cataract patient, you know, and under 40, if it is really very high hypermetrop, I've not done it personally, but you know, I wouldn't have great objection to doing that. But for high myop, I normally discourage them for the reasons which you know we've discussed earlier, and I've seen these patients with total detachment post surgery with ICLs and as well as clear lens extraction, you know, and the chances of infection we all know and all that. So my personal views is discourage them. Thank you.
Thank you.
So we have looked at this patient who are under 40. Mostly these are myopes and sometimes high myopes. Because they want to get rid of these thick glasses. And even that you go and do the 360 degrees, which some people do, I'm not sure. Even when there's no change in the retinal factory, the RD chance is very high. So we looked also our patient as well as the international literature. And now we advise the patient, if you are under 40, we do not want to do the clear lens exchange. Yeah, 50 plus, you know, and especially what sir you were saying is, if it's hypermetrop, maybe you can make a point. For myopes, I think it's a dangerous option to do the just a cataract surgery because you want to improve your refraction, RD.
Thank you.
Idris, your reply should also include the question: should we do under 40 hypermetro, RLE?
For the vitreoretinal person, this perspective should be made very clear to the patient that posterior vitreous detaches with the age. With high myopia, it detaches earlier, much earlier. With the added pathology in the retina, that invites more earlier posterior vitreous detachment than it would do in high myopia. The other problem with the high myopia is the vitreous chiasis, that it looks like posterior vitreous detachment, but there is a thin layer of the vitreous that remains attached to the retina. Now, these two added problems adds more to the job of the vitreoretinal surgeon when he goes and does the surgery in these cases. So, if somebody wishes to undergo refractive surgery at the young age that you are talking about, either hypermetro or myope, he must be made very clear in his mind that this is an added risk, number one. Number two, the cosmetic motivation is so high in these kind of patients that even though you explain to them these particular problems, the cosmetic motivation is so high that they would go and would say that this is the risk they are going to take, and they will undergo these surgeries. But the result that you face, even in 100 patients, if you have one patient that has vitreoretinal problems and then goes to the stage of blindness that we've seen in society, the pain of doing the surgery, and you always feel that you did the surgery, you added the risk, the patient did not listen because of the high cosmetic motivation and went blind. The pain is so much for the patient as well as for the surgeon that at times it is very difficult even for the surgeon to go for these kind of surgeries in these kind of difficult situations. So my tendency would be, if you can be with the glasses, don't undergo these kind of cosmetic surgery at young age. That will be the message that I will impart to the patient.
Can I just add one thing? Sorry. In such patients, one thing we need to keep in mind, that the consent should be a very detailed one. It shouldn't be like this कि मैं आपकी refractive surgery करता हूँ जिसके फायदे नुकसानात आपको बता दिए गए. It shouldn't be like this. When we used to do in UK, Tanveer Bhai knows that we used to do a detailed consent. इसमें 2 pages होते थे and patient had to sign at least 30 places और उसकी हम recording करते थे and we used to keep that recording. Because when you add extra complications, so you need to, and you have explained it to the patient, then it's fine. But the patient may tomorrow tell you that you didn't explain me and then you have to go to the court. There's a lot of litigation going on nowadays. So consent should not be like this, कि मैंने फ़ायदे नुकसानात बता दिए. It should be every drawback should have been explained and the patient should sign each section. So मेरा जो consent form होता है उसके ऊपर तकरीबन को 25 के 28 जगह पे patient को sign करना पड़ता है and then I give them a video कि वो फिर वो sign करता है कि मैंने वो video देखी है. So it should be very detailed one to protect yourself.
I just wanted to add one thing to the
informed consent.
Salim, please. Sorry. I just want to add something to the high hypermetro. There is, these are difficult beasts. They're difficult cataract surgeries, whether, clear lens or otherwise. And we need to be careful about 2 things. There is a term called relative anterior microphthalmia. These are again very difficult cases. And the other thing is UV diffusion syndrome. These are microphthalmic eyes as well. They can be microphthalmic. You just don't do their simple, biometry and just go for the lens implant of 34 or whatever. So these are difficult cases. They should not be done by average cataract surgery centers where there are hardly they should be done at GA with the CO2 monitoring and all that. So these are the relative anterior microphthalmia is the take home message here. Thank you.
Sir.
So I agree with what Dr. Idris was saying, that the patient's motivation is such that they want to get their cosmetic improved. I see this Afghani lady.
Sir, mic please.
She got minus 23 diopter glasses in both eyes and she wanted it. So the problem is, patient can turn up their back on us, and sue our hospital. Your doctor did not even tell us. Now, 12 months afterwards, my retina is detached. We have to get informed consent. And you're going for these cases, I can tell you a simple case that you're putting trifocal lenses in the patient and the patient comes to the hospital that your doctor did not explain to me that there's 20%, 30% chance that I'm still going to need glasses. So now I can't see the distance, I can't see the near, and you charge me 500,000 rupees, whatever, and hospital should go back. Informed consent. You need to discuss everything with the patient and then do it. And you need to document it. I think we used to do it in England very often. Maybe here we don't do it. But in my hospital, we'll do it because the hospital has been sued.
So just to add to all of these points, I think the pathology has been explained really well with all of the experts here. The data that we're seeing now in high myopes, so we have very, very little data in sort of hypermetropes, so I don't know about that, or emetropes, because most of these surgeries are being done in high myopes. So a European cohort has shown almost 20 to 30% risk of detachment. Now the problem is, you're going to say कि मैंने इतने patients किए मुझे तो कभी detachment नजर नहीं आई. The detachment will not happen in the same year or in 6 months. The risk of detachment goes extremely high in the next 10 years because you've accelerated, like Dr. Eddy said, you've accelerated the PVD creation process. So it is a very high risk surgery. And if you're going to routinely do it, I would highly recommend informed consent. I personally have stopped doing refractive lens exchange in someone under 40, and even if they're over 40, I get an OCT and see if that the PVD has been induced already, and if it has been induced, then I go for surgery. So this is a case that was given to me by Dr. Misbah. This is a 19-year-old high myope that was operated 2 months ago, as far as I remember, for both of the eyes for refractive lens exchange. Now this is a very dramatic sort of case. Obviously 2 months is a very short time, but you can see she has developed bilateral retinal detachments post-surgery. Now who did it, why they did it, I don't know, and it doesn't matter, but the take-home message here is be very careful when you're doing refractive lens exchanges. You have better options. I know they're more costlier, but you have better options than refractive lens exchange. So just to continue, I'm sort of going to skip, because we have very little time now, so I'm going to skip over sort of our complications in terms of videos. I'm just going to continue this discussion. When we cannot do LASIK, what is your choice of surgery? To all of the panelists. So the last 2 surgeries are keratoconus. We'll do this in the next sort of session. let's focus on the first three surgeries. What do you do when you cannot do LASIK and the patient still wants that we undergo? So the first, I think I should amplify this. The first one was referred to Hashmanis. So that's a very good point. Thank you.
Isme jumla, just add one jumla, one sentence should be added to this. Who said refer to Hashmani? But never got anyone in last 40 years.
तो खुद पहुंचाया करेंगे.
Just to put the record straight.
Noman, depend करता है कि आप LASIK क्यों नहीं कर सकते हो? Is it because of the high refractive error, or is it because of the thin cornea, or whatever?
So do you have different preferences?
If it's a high refractive error, I mean, recently I've done quite a few ICLs, and I think patients are happy. But again, as I said, these are the surgeries which are high risk and high myope, very high myope. I've done like recently -17 and -14. You should have that informed consent, not only from the patient because they're a young patient, but involve the family as well.
From the panels?
I think PRK or the trans-PRK, they should be the option. If the not too much high hope. The limit is about the 4 something. If beyond this number is, then I think PRP is not worth it. If the number is decreased, you can go for the PRK also.
So you're talking about suspicious, so you're talking about lower numbers,
yes,
but
lower
a little
numbers.
bit of suspicious deposit.
Yes.
Okay.
Yes, definitely PRK is my choice in this case, agar LASIK nahi kar sakte. But I don't recommend taking off more than 6 diopter, Dr. Isra. जब भी 6 diopter से ऊपर जाते हैं, there are more chances of getting corneal haze, or that haze is not going to be taken care of. वो फिर बड़ा मुश्किल हो जाता है. कोई treatment नहीं है उसके लिए. Even up to 8 I have done it, but I don't recommend it. With MMC as well, I always do PRK with MMC on the cornea.
I say only up to the 4 or 4.5, not more than.
He's not talking about high mark.
Not more.
He's talking about a little bit of suspicious borderline.
So 6 diopters, yes, you can do it, because if you look at the literature, people have done it with
4 is
minus
okay,
8 diopter.
not more than 4.
So this is sort of very interesting sort of discussion, because Abbu has always sort of steered me away from PRK के haze ways हो जाएगा. तो मैंने PRK बहुत कम किया. I've started now in low myopes. But when I see the discussion on international forums and international doctors, I've seen people do PRK routinely for -8, -9, and they say that haze का कोई problem नहीं है. So maybe there is something that we are not doing that they're doing that we need to figure out, which I will work on in the next couple of years. I want to see what we are doing that they're not doing. But the cases that I've done till about -5, and I've had no haze problem so far.
Noman, it could be because of the chi.
Me? With mitomycin.
However,
that is a good question. So, sorry, let me just. So, mitomycin C you're giving primarily for haze, right? The problem with haze is not just mitomycin C. I don't know if that truly works or not, because it's just mitomycin C works on sort of actively dividing cells. I do it because it's a protocol. The haze problems for me comes from extensive dry eye patients. So we're not sort of looking at dry eye patients, and if you look at like real dry eye patients, you'll actually see some subepithelial haze before surgery also. So why is that haze coming? And that haze is coming because your keratocytes are sort of uncoupling already. You do PRK on these patients, they will definitely develop haze. Now, there are also 2 types of hazes. So early haze, you're going to get rid of, no problem, you don't have to sort of worry about it. But if you get late, deep-seated haze, that is usually, a lot of it is because of very dry eye patients that you didn't screen. Some of it is obviously idiopathic, we don't know. But if you have a dry eye patient, do not go for PRK. You're going to invite trouble. Especially if you're going into deep stroma, the deep stroma keratocytes will uncouple as soon as you do the surgery.
I mean, myself, I haven't seen haze since I've started using mitomycin. It used, क्या चीज़ थी? 3 minutes के लिए जी. 3 minutes के लिए. In every case.
3 minutes.
So mitomycin itself. So mitomycin itself.
Sorry, not 3 minutes, 30 seconds.
Mitomycin itself, I don't have a problem with it because it has a lot of protocols. If you go on the sort of internet, people have used it for 10 seconds and they've used it for 5 minutes. I mean,
You don't titrate with the number of this
diopters.
myopia के हिसाब से नहीं करते आप?
6 से ज़्यादा वाले को तो नहीं करते जी.
नहीं, -6 से नीचे वालों को सब केसेस को -3, -4 सबको आप 3 मिनट से लिए आप लगाते हैं.
Sorry, 30 seconds के लिए.
30 seconds.
Yeah, I said 3 minutes or 30 seconds.
Yeah, so similar. We also do.
जी, concentration is the same always. लेकिन
Sir.
ये थोड़ा सा हटके थोड़ा सा कमेंट है कि इतनी रेटिनल पैथोलॉजीज के बारे में हम लोगों ने बात की. दिस इज ऑल प्री ऑपरेटिव. हम देखते हैं, वी डोंट सी व्हाट हैपन्स टू द पेशेंट्स आफ्टर रिफ्रैक्टिव सर्जरी, व्हाट हैपन्स टू द रेटिना, व्हाट हैपन्स टू द existing pathology, what happens to the pathology that we treated, and we do not see what we did. We induced the new pathology or not. So it will be a good idea to start the practice of looking at the retina of the people in whom we found the pathology first, we treated, and then what we induced after refractive surgery. So these patients must be looked after for the retinal pathology after the refractive surgery, not only before refractive surgery. That's my comment.
That's a very good point. And my point would be that pre-operatively सिर्फ retina को नहीं देखना है, cornea को भी देखना है. So please, epithelium को. Epithelium, keratocytes, main nerve plexus.
LASIK की बात हो रही है तो post operative cataract surprises आती हैं. And there was a time where people used to replace lenses. लेकिन recently I've done some cases जो कि refer हुए. One eye done with a -3, -3.5, and we managed that with LASIK, and then did the other eye as well. So that's one good use of LASIK is that when you get post-operative surprises in myopia.
Yeah, that's a very good point. Okay, any other points? So if you want to comment on Artiflex versus ICL, I think you're the only one that does both of them.
झगड़ा हमेशा रहता है. I started with Artiflex in 2007. First Artiflex implant in Pakistan I did in 2007, and for many years I continued with the Artiflex. I was very happy. Then suddenly Dr. Idris came in and he stopped me. कि इसमें तो ये problems हैं कि endothelial cell loss और ये सारा. तो हम तो सबके endothelial cell loss काउंट करते थे पहले भी, बाद में भी हमने. फिर इसके बाद 2-3 साल तक हमने रोक दिया. जितने भी केसेस के थे सबको हमने रिव्यू किया and all were fine. So अच्छी बात ये है डॉक्टर इद्रीस कि अभी मैंने 2 हफ्ते पहले नुमान को बताया कि एक केस आया मेरे पास जिसका I did in 2007, both eyes, Artiflex, 6x6, very happy. और endothelial cell count was more than 23-2400. तो this is a very good lens, number one. फिर आपके कहने के बाद हमने स्टॉप करके फिर दोबारा शुरू किया, फिर ICL शुरू किया. ICL कुछ डाले, ICL बड़ा मज़ा आया, लेकिन फिर ICL स्टॉप किया कि यार इसमें भी मज़ा नहीं आ रहा. वॉल्ट साइज और ये साइज और सब देखो तो फिर Artiflex. तो अभी भी मैं कंफ्यूज हूँ, लेकिन स्टिल माय प्रेफरेंस विल बी फॉर Artiflex लेंस. एंड अभी लास्ट वीक तकरीबन 1 महीने पहले मैंने फर्स्ट Artiflex टोरिक डाला है एंड अबाउट -3 सिलेंडर, एंड दैट पेशेंट इज डूइंग वेरी फाइन. जो डॉक्टर असफर ने भी मेरा काम देखा है वो. सो बोथ आर वेरी गुड लेंसेज. और बट दिस फियर कि Artiflex में या आर्टिजन लेंस में आपको एंडोथेलियल सेल लॉस होगा, वो बिल्कुल क्योंकि ये आई एम 2007 एंड अभी तक मैं नोमान से कहता हूँ कि पेपर लिख दे, क्योंकि डॉक्टर इद्रीस ने हमें कभी पेपर लिखना नहीं सिखाया, तो इसलिए हम नहीं लिख सकते. तो मैंने नोमान से कहा कि एक बनाए इस पर. तो ICL इज़ ऑल्सो वेरी गुड, लेकिन माई प्रेफरेंस इज Artiflex नाउ. तो पलड़ा जो है वो ऊपर नीचे होता रहता है. But yes, it's a very good lens, and ICL lenses भी मैं तकरीबन 10-12 साल से डाल रहा हूँ, and they are doing very fine. Any question about
If there's any other questions from the audience, please let us know, because I will be concluding the session. Yes, Mustafa sir.
Sir, I want to raise one point here. I have seen so many patients, not so many, but in my practice there is one very common complication, post-LASIK herpetic keratitis. So what do we look for it before going for any refractive procedure? And if it happens, how do we manage? How frequent and which topical steroid do we prefer? And what is the role of systemic antiviral in such cases? And this question is for the panelists and for all the senior consultants sitting over here. And the second question is that if there is any problem with the flap, especially in the microkeratome LASIK, and you want to replace it, then what is the treatment plan after you replace or you reposition the flap? Is there any particular treatment, topical, systemic? So these are two questions from the panelists.
So sorry, just one clarification on the second. You were saying replacing the flap?
No. Repositioning of the flap.
Okay.
Yeah. If the flap is dislocated and you reposition it next day or a week or so on, then how do you manage topically, systemically? What is the treatment plan for that patient?
Okay, so we can discuss that. I also have a video I can show you. So yeah, so the two questions are: what do you do for basically prophylaxis of herpetic uveitis, herpetic keratitis before surgery if you have a history, or how do you screen them? And we'll go to the second question after that. So
yeah, if somebody has a herpetic uveitis या there is a history of herpetic keratitis, तो फिर तो आप तो थोड़ा सा एहतियात करनी है और उसको बताना है पोस्ट ऑप स्टीरॉइड्स की ज़रूरत अगर पड़ती है तो that might cause a recurrence. And recurrence को treat आप उसी तरह करते हैं जैसे हम कोई भी herpetic keratitis करते हैं. But as you are saying herpetic uveitis, you have seen so many
keratitis,
cases
of uveitis मैंने गलती से
you have said keratitis. So many cases of keratitis after LASIK.
You examine the patient, the corneas are absolutely fine. Okay, but later on that patient developed herpetic keratitis, and patient reportedly said that I went to the doctor, he did femto, he did excimer, but later on doctor told me this is the complication of this procedure. So what do you check for that before going for the procedure, and how do you manage it later on?
Dr. Mustafa, herpetic keratitis has a very specific configuration like dendritic ulceration. ठीक है? If it's there, it could be the possibility कि patient को अब हुआ है. It has nothing to do with the previous history. Could be the possibility. ठीक है? We usually take history, and everybody is advised to take history before going for any kind of refractive procedure. कोई भी बीमारी होगी तो आप पूछेंगे उससे कि आपको आंखों में पहले कुछ भी हुआ हो बताओ. वो बताएगा. अगर फॉर एग्जाम्पल वो नहीं भी बताता तो then there is no other way to find it out कि इसको पहले कभी हुआ है या नहीं हुआ. Am I right?
Yeah, I must admit I've never seen in the last many years a patient of herpetic keratitis after having refractive surgery. अभी मैंने हशमानी साहब से भी कंफर्म किया है, वो भी कहते हैं मैंने भी नहीं देखा. तो I think it's very rare something to happen. You might have just by chance might have got a couple of patients in a row, but it's a very rare thing to happen. जी.
Cause a relapse. और यही वजह है कि जब पैक CXL जब हम करते हैं कुछ कंडीशंस में तो herpetic की हिस्ट्री हो तो हमें पैक CXL भी नहीं करना चाहिए क्योंकि वो रिलैप्स कर सकता है. But I don't know. I mean, maybe patient has not disclosed the history properly. और हमने शायद उसको कुरेदा नहीं है ठीक तरह.
But the treatment was you don't have many options anyway.
हाँ मुस्तफा, आपका जो दूसरा क्वेश्चन था कि अगर फ्लैप डिस्प्ले हो जाता हाउ यू ट्रीट इट, तो यू विल गो एंड रिप्लेस अगेन इन सेंटर एंड देन पुट द BCL for 5 to 6 days, and then you can continue the same treatment. There's no any change in the treatment, but you have put the BCL.
In addition to BCL, we can apply suture as well.
हाँ.
Chances of again displacement. So
Yeah, this is another option you are saying too.
it's better to
Yes.
apply suture than.
So have you ever had a case where you needed to put a suture?
आप बात कर रही हैं complete displacement की, यानी कैप की बात कर रही हैं, फ्री कैप.
अगर फ्री
He's
फ्लैप
talking about inverted flap right after this. So एक surgery में quickly दिखा देता हूँ. It's the same flap inversion. This is my protocol. So if you can see here, let me just show you. So this is sort of the inverted flap. ये first day है उसका. So basically the two halves of the flap are very tightly packed. और उसके ऊपर अगर आप देखेंगे तो epithelium, it's very interesting for me कि the epithelium sort of bridges and it towers over and it doesn't go into the stroma. So if you see, in the very next day, you will see a bridge of epithelium and then you will not see anything in the stroma. It's very interesting finding for me. So what I do basically is, कुछ नहीं है, we just raise the flap. But when we raise the flap, ये बहुत tightly adherent होगा. So once it's gone, you just want to dissect under और उसको raise करते हैं. आहिस्ते आहिस्ते वो flap को raise करें आप. You can use a smaller tool. Sometimes it's not this easy. कि वो जो spatula है मैंने डाला है वो फौरन निकल आया. Sometimes I need to use like a smaller dissector, जो femto का dissector होता है, उससे मैं dissect करके फिर निकालता हूँ and then I put it back. You iron it like a normal sort of LASIK procedure. And with any sort of LASIK procedure, I would advise कि मैं पहले in my really early days, I used to iron a lot. You don't need to iron a lot. Just once or twice is more than enough. Apply BCL, he'll be fine the next day usually. And then obviously apply, usko advise kare कि वो rub ना करे eyes and all of that stuff. I hope that answers the question.
Numan, आप कभी वो use नहीं करते hypertonic saline?
Hypertonic saline at the end to see the flap edges.
अच्छा नहीं, इसमें in particular cases जिसमें flap inversion हो गया, इसमें भी अगर आप ये अगर properly नहीं आ रहा, तो आप hypertonic saline, normal saline.
Visualization करते रहे. That's an excellent one. So you can put hypertonic saline to sort of visualize the flap. मैंने नहीं use किया आज तक. But that is a very good point. मेरे दिमाग में आया नहीं था. Even though we routinely use it. Okay, so I'll show you a complete flap dislocation also. So the question is, in a complete flap dislocation, how many sutures do you need to apply? So let's go to the surgery. So this is the keratome. Flap dislocation usually इसी में होता है. So now when I'm coming back, you see there's nothing there, right? So अब क्या हुआ? This is a complete flap cut, completely उड़ गया. अब वो कहाँ पड़ा हुआ था? It was inside the keratome. I was trying to find the flap, वो मुझे मिल ही नहीं रहा था. फिर 5 मिनट बाद realize हुआ कि उसके अंदर पड़ा हुआ है. So I took it out. We then put it back. So before I show this, studies have shown that even in ALK, anterior lamellar keratitis, you can just put a BCL. You don't need to put any suture. But I'm a little bit afraid of it sort of getting dislocated. Even if you just put a BCL, it's usually okay. But what I did was, I just re-established the hinge. I just put one suture to re-establish ताकि वो कहीं और गायब ना हो जाए. And it wasn't a tight suture, it was a very, very loose suture. Just so अगर dislocate भी हो तो आँख से गिरे ना. That was the whole point. Because if you put a tight suture, your flap is going to completely sort of move away. And you're not, because this is not a cataract sort of thing, the flap is free and it's very mobile.
So you put in a suture and then a BCL on top of that?
One suture and BCL, that's it.
Thank you. Studies that suture application is better than to apply BCL, just BCL. And there are people that have applied 4 sutures and some have applied 1 suture.
So I think 4 suture is a little bit excessive. Because why do you want to put that many sutures? आप एक suture लगा दें, at least you just want to save the flap, right? So you save the flap, एक suture लगा लें. अगर वो फिर से dislocate हो जाता है, then fine, you go and put 4 sutures. I think it's excessive.
आपकी hinge भी तो एक ही जगह पे होती है ना?
I hope that answers the question. Any other question? Okay, so thank you so much to all of the panelists who have taken out their time to be here. We're going to conclude the refractive session here. We will take about a 10-minute break and then we will reconvene for the keratoconus session. Thank you everyone for being a great audience.
Bismillah ar-Rahman ar-Rahim. May I once again request the respected participants to please take your seats. You may take your cup of tea and your snack box to your seats and continue to eat. Bismillah ar-Rahman ar-Rahim. Now we are starting the second half of our today's pre-congress workshop. The second half will comprise largely on the keratoconus its diagnosis, the various ways and means to treat it, and the follow-ups. And for the panelist, I'm inviting again Professor Mahfouz Hussain. Professor Mahfouz, please. Professor Mahfouz. Professor Mahfouz, you all know him. He has a very strong background of performing keratoconus cases. His knowledge, his basic knowledge and his expertise on keratoconus and its diagnosis is excellent. And he's always very generous to come right from Peshawar and join us. I think this is the third time he is attending our pre-Congress workshop. Thank you, sir. The next I will invite is Dr. Tanveer Chaudhary. Dr. Tanveer Chaudhary is an eminent cataract and refractive surgeon of Karachi. He is currently at Liaquat National Hospital and South City Hospital. And besides being a refractive and cataract surgeon, he also has a special interest in retinopathy of prematurity. And he is doing a lot of work on that also. Professor Zaman Shah is our guest from Peshawar. He is a cornea and refractive surgeon, and he has a special interest in keratoconus. And the next half of today's is after we finish here, 3 o'clock, we will be there at Hashmanis Hospital, where Professor Zaman Shah will be. He will be showing some hands-on new techniques in treating keratoconus. Thank you very much, Professor Zaman Shah. Dr. Mustafa Kamal is our local hero here, corneal refractive surgeon. He is currently at the South City Hospital, but he is known to have a long association with the Al Ibrahim and Al Basar Foundation. So thank you for coming here. May I now again hand over the rostrum to Dr. Noman Hashmani.
So thank you again, Dr. Misbah, for the introductions. We have 4 very experienced surgeons in keratoconus, keratoplasties, and I think we can learn a lot from them and see how we can sort of manage these cases. So for the audience, I want someone, preferably a resident, to answer this. This is a 19-year-old female, came to the clinic for a routine checkup. The refraction, her refraction was -2 with -4 sil, -3 with -3 sil, and K readings you can see. Does this person have keratoconus? Any one person come and please, anyone, does this person have keratoconus? आप लोग ही बता दो. बोलो माइक पे. So she's saying that we cannot exclude keratoconus without topography. So the reason I've kept this case is that we routinely get these patients that have been diagnosed as keratoconus based on the K readings. And that is not a good practice because K readings do not tell you the entire story. So if we've already seen this case in our LASIK workshop, and this is an absolutely normal case. There is absolutely no problem with this person's cornea, and this is not a keratoconus case, even though the K readings were above 50. And the Bellin embryo is your display.
Noman, मैं just add करूँगा आपकी बात बिल्कुल ठीक है. I've seen quite a lot of cases K readings जो difference आता है K readings का बहुत ज़्यादा और कभी-कभी वो हमारी नॉर्मल थ्रेशोल्ड से ऊपर होते हैं दे कैन हैपन इन हाई एस्टिग्मेटिज्म, और आपको टोपोग्राफी के बगैर उसको कभी भी डायग्नोज नहीं करना, बट सम पीपल हैव बीन एडवाइज्ड CXL फॉर जस्ट ऑन द बेसिस ऑफ दैट। तो एक थ्रेशोल्ड को क्रॉस कर लेना का मतलब ये नहीं कि वो केराटोकोनस है, so be aware of that. Thank you.
Okay, so sure, sir.
Take it. I would like to add another point is that by definition, if anything's like in the K reading that is above the normal range, so we should be suspicious, even if the pentacam comes out as normal. So we should take that case as serious, not ordinary case.
So then what would you do in this particular case? Is there any intervention that you're planning? What are you planning for this?
Most of the time, I would like to go for the observation in this case.
So that's a good point. You can never be too careful, so you should keep such cases into observation, as Professor Jaman Shah said. Okay, so now a question to the panel. What is the most effective way of diagnosing keratoconus? Anyone want to chime in? How do you diagnose keratoconus? What is the most effective way of doing it?
For audience or for panel?
Sorry?
Is a question for audience or for the panel?
For the panel.
Is there any doubt we won't be doing topography?
Topography? Okay.
Yeah, tomography. I mean.
Oh, yeah.
I think any condition you diagnose, or any condition see it as a whole. See the patient as a whole, as one patient with his or her background, a history. Is it a frequent change of glasses हो रहे हैं, या उसको हाई एस्टिग्मेटिज्म है लेकिन वो स्टेबल है, उसको एलर्जी की हिस्ट्री है, कोई कॉन्टैक्ट डर्मेटाइटिस है, वो किस इलाके से आया है, उसकी रूटीन क्या है. सो डोंट जस्ट सी द, मैं हमेशा कहता हूँ, मुझे पेशेंट आते हैं कभी रेफ़र होके तो सर ये टोपोग्राफी हमने कराई है. नो, डोंट सी टोपोग्राफी, डोंट सी OCT. दीज आर टू हेल्प यू आउट. क्लिनिकल डायग्नोसिस आपकी होगी और आपने उसको कंफर्म करना है या एवेल्युएट करना है, एक्सक्लूड करना है विद इन्वेस्टिगेशन. सो डोंट सी द इन्वेस्टिगेशन फर्स्ट. मेक श्योर कि आपका अपना क्लिनिकल नॉलेज क्या कहता है. तो पूरी हिस्ट्री लेना, एग्जामिनेशन करना और उसके साइंस देखना. अर्ली केराटोकोनस में आपको कोई साइन नहीं मिलेंगे. एंड देन इफ यू आर सस्पिशियस, गो फॉर टोपोग्राफी और टोमोग्राफी. And
I would like to add one point that every patient with history of the allergy or in their relative should undergo screening for the keratoconus. So most of us when we are sitting in our clinic, usually when the patient comes with allergy, we do some prescription and send the patient back to home with an advice that come again and again. But the thing is that every allergic patient should be taken as suspicious for the keratoconus.
Okay, that's a very good point. So that sort of segues into what the next question was, that what are the risk factors of keratoconus. But I just want to sort of be a little bit more clear. So we've got many patients that sort of come in with the diagnosis of keratoconus, but they're not actually keratoconus. Either they have normal corneas or they have some other corneal pathology. For example, just last week I saw a patient that was actually Terrien's marginal degeneration, and he was diagnosed as keratoconus. He had a suspicious looking sort of superior cone, but when you see the person clinically, you can see the corneal thinning superiorly, and it wasn't a case of keratoconus, it was Terrien's marginal degeneration. So that really goes into the point of what Dr. Tanveer was trying to say, is that look at the patient, don't just look at the diagnostic reports. Additionally, all of the diagnostic reports you see, whether that is OCT, whether that is topography, whether that is the epithelium, they are inherently dependent on good data. So if you've seen a keratoconus and if you've seen a topography report and they have given you some sort of suspicious looking topography, however, it doesn't fit into sort of any criteria, especially if the patient has some sort of corneal pathology, you want to go back and check if the segmentation was done properly. If the segmentation is not done properly, you cannot rely on any of the maps. That is a very important point. What risk factors for keratoconus do you ask for in your patients? So we've gone through some of them: allergies, contact dermatitis. What other risk factors for keratoconus do you look for?
एक चीज़ मैं यहाँ point out कर दूँ. some people do have ectasia, unilateral ectasia, and that's not keratoconus. Some children do have a habit of rubbing one side of their eye quite frequently from childhood. So make sure कि आप differentiate करें, don't jump on. और बहुत सारी ectasia post traumatic भी हो सकती है. So yeah, I will let Mahfouz or other explain the risk factor, but just make sure every ectasia, unless it's bilateral, is not keratoconus.
अच्छा, थोड़ी सी ये जो रबिंग है इसके बारे में थोड़ा सा वाज़ेह कर लूँ कि if you rub with the palm with the soft structure, there will be less harm. When you rub with the knuckles, it will give more harms. So the effect is of the rubbing is more when you rub the eye with the hard surface. But when you rub with the soft surface, the rubbing effect will be less. So this is important in keratoconus.
So, Mustafa, Professor Mahfouz, if you want to highlight any of the risk factors?
Just the one that we are not very familiar with, and the Western world is familiar with. जो बाकी के risk factors हैं ना, ये तो डॉक्टर साहब ने बता दिए, rubbing, itching, dermatitis, all those things. One is the genetic factor. That's being highlighted recently in the West, or कुछ countries में, all those patients, the relatives of the patient, they do genetic testing on that, and particularly on the children, and particularly on the patients who have got VKC. There are about 41 genes that have been identified with the genetic predisposition for the keratoconus. So perhaps that's a very big risk factor, and we are not yet into that, but we need to know it anyway.
Mm-hmm. So I would like to add something in the initial workup for the keratoconus in clinic. So the most important thing is that the auto-refraction and the subjective refraction of the patient. If the patient has got astigmatism, you should see where the steep cornea lies. So the two different types of steep corneas are prone for the corneal ectasias, not for the keratoconus. Number one is the against the rule, and number two is the oblique astigmatism. So we definitely Noma will tell what is the importance of oblique astigmatism in developing ectasia. So then you do the refraction of the patient. In this part of the world, we are handicapped with the help of optometrists. They do refraction, we just check and what's going on. So the refraction is very much important. How you check it, how the patient's glasses acceptance is, and where the steep cornea lies, and you minus the corneal astigmatism with the lenticular astigmatism if there is any. I saw a patient last week. That patient was diagnosed as keratoconus. But when I checked that patient was not the patient of keratoconus, that patient was the patient of posterior lenticonus. So this is the way how you go for the ectasia. And if you pick up on auto-refraction and subjective refraction that there is ectasia, then you go for the advanced investigations like pentacam, tomography and other things, the epithelial mapping, posterior cone and everything. Family history, I agree with all the panelists, family history is very much important because I have seen so many patients with forme fruste keratoconus and their cousins have got keratoconus and they underwent CXL or they underwent refractive surgeries. So this is very important. If you see anything in patient, you should ask about the family history.
Excellent. So that was going to be my next question, but everyone's answered it. So.
Ms. Basab.
Sorry.
Dr. Mahfouz. बहुत पहले की टीचिंग्स में था कि जब आप उनका रिफ्लेक्शन कर रहे हैं तो सीजर रिफ्लेक्स देखना चाहिए. अगर सीजर रिफ्लेक्स आ रहा है तो मोस्ट लाइकली टू बी केराटोकोनस.
ऑयल ड्रॉपलेट सीजर रिफ्लेक्स.
आप इस स्टेटमेंट को कैसे लेते हैं?
प्लेसिडो डिस्क एग्जामिनेशन.
सर आजकल हम रेटिनोस्कोपी करते ही नहीं हैं और इवन कि हमारे ऑप्टोमेट्रिस्ट भी रेटिनोस्कोपी नहीं करते. लेकिन सीजर रिफ्लेक्स या ये चीज़ें तब आती हैं व्हेन यू हैव गॉट अ क्लिनिकल केराटोकोनस. जब आपके पास क्लिनिकल केराटोकोनस नहीं होता, वी आर टॉकिंग अबाउट द डायग्नोसिस ऑन टोमोग्राफी. ये जो टोमोग्राफी का केराटोकोनस होते हैं इनके ऊपर सीजर रिफ्लेक्स होता भी नहीं है.
So that's a very important point. So रेटिनोस्कोपी में जब आपको सीजर रिफ्लेक्स आता है, that means anterior surface छिड़ गया. If it's on the anterior surface, you will see a scissors reflex because it's an anterior surface reflection. But if it's just like Sir said, कि posterior surface पे सिर्फ है, you're not going to see it. So you still need to do your investigations in the early stages of keratoconus. A very, very good point.
Similarly, I would say when it's on the posterior surface, आपकी K readings भी बहुत सारी change नहीं हुई होती हैं. K1 and K2 जो है वो इतना change नहीं हुआ होता है. और ये बहुत एडवांस जब हो जाते हैं तब आपको ये साइंस मिलते हैं, फ्लेशर्स रिंग, वोक्स ट्रायर जो भी हैं. आप लेकिन रेजिडेंट्स जो हैं या जो बडिंग ऑफ्थल्मोलॉजिस्ट हैं, दे शुड कॉन्सेंट्रेट, दे शुड एक्चुअली, मैं हमेशा कहता था, डाइव इनटू द कॉर्निया. कॉर्निया एक पतली सी लेयर या प्लास्टिक की शीट जैसे नुमान ने कहा था नहीं है. कॉर्निया हैज़ गॉट लेयर्स एंड लेयर्स एंड लेयर्स. और जब आप कॉर्निया को एग्जामिन करें, डाइव इनटू द कॉर्निया फ्रॉम एपिथेलियम एंड रीच द एंडोथेलियम, और वहाँ इन बिटवीन जो भी आपको साइंस मिलते हैं, दे विल बी सीन in advanced cases. Unless you look for them, you will miss them.
Okay, so so moving on, I just want to highlight, we've gone through a lot of this already, but I want to highlight what are some of the key findings on a topography of a obvious keratoconus case, so we can all differentiate what a keratoconus is from a normal cornea. So any one of the panelists would like to comment on this topography? I think it's fairly straightforward.
Yeah, it is straightforward from the picture, but actually I cannot see the parameters. ये thinning सिर्फ superior है कि inferior है?
Thinning जो है वो, sorry, thinning in terms of the thickness is only it's inferior temporal.
Is it pellucid?
No, this is not pellucid. Because this is an inferior temporal cone. I understand why you're saying it because of the butterfly effect. But this is an inferior temporal cone with inferior temporal steepening. So that's a very good point. So a lot of us get confused. Obviously, he doesn't have all of the data that I have on this patient. A lot of us get confused when we see the butterfly pattern of the corneal topography. But always remember, pellucid जो होता है वो outside 9 mm zone है. So you can sometimes get this sort of butterfly pattern in a keratoconus case. How do you differentiate between the two? You go and you see the back pictures on the Scheimpflug image. If there's peripheral thinning, then you've got a true pellucid case. But if there's no peripheral thinning and you've got a central sort of cone that's shifted, then that's a keratoconus case. So sometimes this can be absolutely misleading. That is a very good point.
I would like to add something in for this patient. If you see here in pellucid marginal degeneration, there is the sparing of 2 mm of the limbal cornea, right? And it involves from 4 to 8 o'clock, right? But in pellucid marginal degeneration, we don't get cone. So if we have got a cone on pachymetry map, then there's a new term called pellucid-like keratoconus. So I would label this patient as a pellucid-like keratoconus because there is the involvement of the cornea from 4 to 8 o'clock, sparing of the limbal 2 mm of the cornea, which is in orange and yellowish color. And on pachymetry map, and on both the elevation maps, I see the cones on the anterior and the posterior elevation map as well.
So pellucid-like keratoconus, you are absolutely right. So very, very good point. So pellucid-like keratoconus को differentiate करने के लिए, my advice would be, you go back and you see the Scheimpflug image, or you do an anterior segment OCT. And if you've gotten a cone that's shifted peripherally, that is keratoconus. But if you've got peripheral thinning, that is pellucid marginal degeneration. So pellucid-like keratoconus is actually a term reserved for tomography. It's reserved for this sort of map because it's just on 9 mm. Yeah, you were saying something, sir.
I was saying that if a patient has got a history of like continuous change in the refraction, and that is in particular to the astigmatism, and this is the topography of the patient. So what would you label this patient?
This patient?
Yes.
This is a keratoconus case.
Keratoconus.
Absolutely,
Okay.
keratoconus. And this is the posterior sort of the BAD display. So I just want to, I want someone to just highlight what you're seeing on this door. So we had the discussion. So I want you to highlight what you're seeing. So if you see this sort of map, you're seeing an inferior temporal sort of cone on the sagittal curvature. Then you're seeing a cone developing. So if you see this circle with intense red coming out, just looking at the colors, you can see that there's a cone on the anterior surface, there's a cone on the posterior surface, and you can see that there's thinning at the zone of the anterior and posterior cones. So the cone will always be on the thinnest point. If you see a cone somewhere else, either your maps are wrong or you have some other disease. So you need to correlate all three of these, and you can see the very same thing on the Bellin embryoso display. You've seen enhancement of the cones. You see a S-shaped curve, if you see here, and you see complete red in its. So this is absolutely a keratoconus.
नुमान एक चीज़ और आप पीछे जाइएगा ज़रा जो एक्सियल मैप देखेंगे आपको कलर कोडिंग आनी चाहिए इसमें बहुत ज़रूरी है टोपोग्राफी जो है वो यही कमाल देती है कि डिफरेंट कलर कोडिंग होती है तो अगर आप एक्सियल मैप देखें तो जहाँ आपको वार्म कलर्स नज़र आने शुरू हो जाएं यानी कि ऑरेंजिश की साइड पे ऑरेंज एंड रेड आने शुरू हो जाए इट मीन्स कि दिस इज सस्पिशियस तो वहीं से आपका सस्पिशन जो है वो शुरू हो जाना चाहिए जब आपको कूल कलर्स आते हैं कूल कलर्स लाइक ब्लू कलर्स या ग्रीन कलर दे आर मे बी आप कहें कि अच्छा इसमें शायद ये नहीं होगा या अर्ली चेंजेस होंगी तो हमेशा जब भी आप वार्म कलर एक्सियल मैप पे देखें ये सस्पिशियस आपकी जो है ना खड़े हो जाना चाहिए कान खड़े हो जाने चाहिए आंखें खुल जानी चाहिए एंड देन यू गो ऑन एंड एक्सप्लोर
So just one last point before we move on. Sir, absolutely a good highlight of the colors, but remember your axial or sagittal curvature, these are the same maps. They are extremely dependent on this fixation of the patient. If the patient didn't fixate well on the machine, these axial curvature maps can give you something that is not there. So you always have to see if the patient has fixated well, and those are findings we can talk about in a more advanced topography course, but fixation बहुत ज़्यादा important है. If you do tangential curvatures, उसमें fixation इतनी important नहीं है, वो ज़्यादा decenter नहीं होता है. But axial curvature में, if for example this is an inferior cone है, if this patient was just looking down, it will give you an inferior cone, a slightly down of the blue light. Okay, so how do you define? We've all been talking about form first keratoconus, early keratoconus, and all of these terms. How do you define form first keratoconus?
This is one of the definition on which consensus is being made. Form fruste keratoconus is a normal eye of a keratoconic patient. Normal eye not only clinically but also topographically. So if you see a keratoconus in the one eye, which is established keratoconus like you saw in the last patient, but the other eye is normal. Normal means normal vision, no clinical findings, no wart lines, no flesh ring, and no topography signs, no posterior elevation. So absolutely normal eye topographically and clinically of a keratoconic patient, they call it form fruste keratoconus. So it is a misnomer actually. The misnomer because it's called keratoconus, but it's not keratoconus.
Okay, so yeah, so very correctly said that one eye is keratoconus, the other eye is normal, is known as form first keratoconus. The thought behind it is that keratoconus is a bilateral disease. So if you've got one eye that's keratoconus, you don't. So for example, if you're doing LASIK surgery and एक eye में कुछ आ ही नहीं रहा है, you don't do LASIK on the other eye because he has form first keratoconus in that eye. And then early keratoconus is something completely else. Okay, so we've already talked about this in terms of LASIK, but how do you? What is the importance of biomechanics of the cornea in the context of keratoconus? So we are going to have a sort of a difference of opinion, I'm sure, but yeah.
Yeah, you know, it has just come after the form fruste keratoconus, so the biomechanics have got more importance in the form fruste form rather than in the subclinical and clinical one. When the keratoconus is clinical, तो तब आपको biomechanics की ज़रूरत नहीं पड़ती है. When there is no keratoconus visible on the topography, then you need something else, and for that you need biomechanics. उसमें ORA या Corvix है. तो कॉर्विस हम लोग ज़्यादा इस्तेमाल करते हैं हमारे पास अवेलेबल है बट और भी इस्तेमाल कर सकते हैं एंड दैट इस even the Corvix doesn't give you a correct diagnosis about the form fruste. लेकिन form fruste by definition no keratoconus on topography, but it doesn't mean no keratoconus on biomechanics. Biomechanics के ऊपर हो सकता है लेकिन by definition it's a no keratoconus on the topography. So when there is no keratoconus on the topography and the other eye has got the keratoconus, then you go for the biomechanics and look for the TBI and CBI and total biomechanical index.
Perfect. Basically, the biomechanics is very much important. Even if you got normal pentacam, in clinically you are suspicious or with the patient has got signs of the allergy, I think the best way is to go for the Corvix ST. And the Corvix ST will tell you some positive findings even in the normal pentacam. So this corneal biomechanics is very important.
Yeah, so early cases of people that you're suspecting into keratoconus, especially allergy cases, eye rubbers, you want to get it done. So what is Corvus? So we've all been talking about what is Corvus, right? So Corvus jo hai, it is an air puff sort of tonometer and then takes a lot of images as the puff of the cornea as the cornea undergoes deformation after the puff. So if you see this video, so there's a puff that goes in, and then there's a deformation of the cornea, and then the cornea comes back. Now from these puff, there's about 20-25 different parameters. Curvature change hai, just sir ne bataya SP1, SP2 hai. So there's various different parameters, and then those parameters and then put into a sort of an index that is easier for us to view. We get a report that's like this. Most of us are more concerned with CBI and TBI because that is what was developed by Renato Ambrosio and his colleagues to give us an easier way of sort of interpreting the biomechanics of the cornea. And then you have this green and sort of red zones. Those green and red zones basically show, so the red is keratoconus corneas, the green are normal corneas. So where does sort of your patient lie in terms of every parameter? And then from that, from these 4 parameters, you get something called a CBI and a TBI, tomographic biomechanical index, and a Corvus biomechanical index. Again, that's just sort of the brief overview of what Corvus is, the importance we've just gone through. Now, another sort of point I wanted to raise is, I've heard a lot of people sort of talk about, even if you go abroad, they talk about, I want to get LASIK, my thickness is really good. My corneal thickness is amazing. Can I get LASIK done? And sort of, even in our doctors, this thickness parameter has sort of been pushed in and inculcated. If the thickness is normal, everything is okay. How does the thickness relate to the biomechanical property, do you think?
Actually, I would like to have some comments on this. Even if you got the cornea thickness about 600, this does not mean that there is no keratoconus. That is basically a bulk of the tissue, which is of the extremely poor quality tissue. And we may have the keratoconus even if the thickness is more than 600. So does not mean that thickness only be counted in keratoconus patient. And if we go for the Caris ST in patient who has got cornea thickness of 600, we usually get a range values.
Okay, that's an excellent point. Exactly what I wanted to highlight. Thick cornea does not mean a strong cornea. Anyone else want to comment?
Just, we don't see the thickness, we see the viscoelasticity of the cornea. So we see actually 2 things. One is the viscosity and the other is the resistance. तो आपने जो वीडियो बताई है ना, उसमें देखिए एप्लिनेशन होती है, तो एप्लिनेशन 2 दफ़ा होती है. एक पहली वेव आती है, फिर एक दूसरी वेव आती है. जो पहली वेव जो इंडेंट होता है, that is because of the viscosity of the cornea. जो rebound होता है, that is because of the resistance of the cornea. That's why they plot a curve और उसमें उन दोनों कर्व्स के दरमियान में टाइम इंटरवल देखा जाता है. So the thickness is not that important, it's the viscoelasticity that's more important.
Excellent. So just to highlight that point, I don't have a Corvus on this, but this was sort of the perfect case to highlight this. The thickness of this patient is 628 microns. So it's a very thick cornea according to any standard. But if you see, like we've discussed before, and even if you look at the K readings actually, I just noticed this, 43 ki K readings. But if you see the anterior and posterior floats, both of these eyes of this patient have anterior and posterior elevations. This is a keratoconus case. Even though the K readings are normal, number 1, and number 2, the thickness is extremely high. So thickness or K readings does not exclude keratoconus. Please have that concept in your brain.
Noman, you know the K readings, we don't see the K readings for diagnosing keratoconus.
Absolutely.
We see the elevations to start with. तो K readings तो हम देखते नहीं हैं. मुझे याद नहीं मैंने आखिरी दफ़ा कब K readings देखी होंगी. तो we don't see the K readings. K readings तो तब होती थी when we used to do topography. We don't do topography anymore. We do tomography. तो tomography में आप तो K readings देखते ही नहीं हैं. K readings तो सबसे आखिर में आ जाती हैं. तो we अगर K reading normal हो या abnormal हो, that doesn't matter. It depends on the elevations के front elevation और sorry back elevation और front elevation और pachymetry कैसी है. ये जो बाकी की readings हैं, they are based on these 2 findings, pachymetry and elevations. तो K readings ये बस पुराना कंसेप्ट चला रहा है K1, K2, K3, KM, ये तो हम देखते नहीं हैं. अगर फ़र्ज़ करें कि K रीडिंग्स नॉर्मल है, K रीडिंग्स 41 और 42 हैं, तो दे आर नॉर्मल, और उसकी पोस्टीरियर एलिवेशन 45 है, तो क्या आप उसको नॉर्मल कंसिडर करेंगे?
This is same case.
So we don't see the K readings and just don't go into reading K1, K2, KM, Kmax. ये आपका टाइम ज़ाया करती हैं. Go for the elevation maps and the pachymetry maps straight away.
So
ये जो actually Bell and Ambrosio display है ना, Bell and Ambrosio display is also based on elevation maps and pachymetry maps and not on the elevation.
So thank you so much. Finally, I've been trying to get this point across for the past couple of years, and another person sort of agrees with me. That's a big sort of thing. Thank you. So K readings, please, is the last thing you want to see. Like Professor Mahfouz, I do not see K readings. I see elevation maps, and I see pachymetry, and I see the BAD display. K readings is the last thing on my mind. Even if it's skewed, for me, it's not a huge deal if everything is okay.
आप अगर Bell and Ambrosio display देखें ना, तो उसमें K readings का तो Bell and Ambrosio 3 में आया है. First 2 में तो K readings थी नहीं सिरे से.
बिल्कुल. तो Bell and Ambrosio का concept यही था. The reason that Michael Bellin जिन्होंने develop किया था, the reason why he doesn't see the K readings is because K readings जो हैं, they are basically derived from elevations. So if your elevations are not normal, your K readings will not be normal, but they are down order from the elevations. So elevations तो जो measurement हम कर रहे हैं, पहले वो elevations को लेता है, and then from that you derive your K readings. So elevations are an infinitely better tool to be diagnosing keratoconus or anything for that matter.
और नवान ये जो best fits fair concept है, ये it does not depend on the thickness or thinness of the cornea. तो again K readings से ज़्यादा anterior posterior floats जो हैं वो ज़्यादा important हो जाते हैं. ये Bell and Ambrosio में best fits fair जो आता है, वो thickness और thinness के ऊपर depend नहीं करता है.
Thank you. Okay, so is there any other way other than coefficient tomography to detect keratoconus? I think we've already discussed this. We have the epithelium map, and that's why I said we are going to discuss this in the keratoconus case. So we've been working a lot on epithelial mapping in the last sort of 3 or 4 years that we've had the machine. We published a paper about in 2018 on wide corneal epithelial mapping using an optical coherence tomography. This was the first paper in the world जिसने OCT based 9mm maps को publish किया. It was published in one of the largest ophthalmology journals existence today. It's known as Investigative Ophthalmology and Visual Sciences. It has been cited, I think, over 60 to 70 times now. In this map, in this paper, we showed the reproducibility of epithelial mapping, and we showed what normal epithelium looks like, so that we can sort of start differentiating from this, differentiating exactly what is the abnormal epithelium. So if you see, you've got 50 to 52, 53, 54 is absolutely normal in the center. You will always have a thicker inferior. You will have a thinner superior. And uska kya reason hai? Aapki jo, if you go and read the paper, there's about 3-4 mechanisms that I jot down kiye the. But the big thing is that you have something called the eyelid. Eyelid jo hota hai, wo superiorly zyada press karta hai, and that leads to sort of thinning of the epithelium. Inferiorly, especially in this mid-peripheral zone, if you see, it actually thins out in the inferior zone, and mid-periphery mein thick ho jata hai. So that is because your eyelids actually don't close in the inferior part, they close at the end in the mid-periphery, in the inferior. So that is why you get a thicker mid-periphery. Now, if you've got someone with lagophthalmus, he's going to have, right in the start, he's going to have an inferior sort of hypertrophy of the epithelium, and now you know that isko dry eye develop hona shuru ho gaya. And this was sort of what we saw. But how does this help us in keratoconus? Keratoconus में the hallmark of keratoconus in an epithelial map. Yes, you get asymmetry and all of that stuff, but the hallmark is if you've got this sort of obvious donut pattern. So if you see thin portion in the middle and you've got a ring of thickening around it, this is known as the epithelial donut pattern. So the thinness is at the thinnest point of the cornea, and then around the thinnest point you get an annulus of epithelium that grows around it. Why? because the job of the epithelium is to maintain a normal refractive, sort of uniform refractive zone of the epithelium, of the entire thing. So decompensate ki taraf ja raha hai, so you can't compensate over this, and it then makes an annular ring. So,
Noman,
epithelium के बारे में कोई comment अगर
आपने heading लगाई थी कि role of epithelium, आप पीछे जाएं, 3-4 स्लाइड पीछे जाएं, और पीछे जाएं. हाँ, is there any other way to detect subclinical and form fruste? तो उसके बाद आप epithelium में चले गए. तो just my understanding is कि epithelial mapping has got no role in form fruste. Subclinical में तो role है. सब क्लिनिकल में ये है कि सब क्लिनिकल है, पोस्टीरियर एलिवेशन हुई है और आपके एपिथेलियम थिन हुई है, लेकिन फॉर्म फ्रस्टे में तो पोस्टीरियर एलिवेशन हुई नहीं है. तो जब पोस्टीरियर एलिवेशन होगी नहीं तो एपिथेलियम थिन कैसे होगी?
So that is a good point. I haven't.
I mean, I'm talking from the literature actually as well. कि जब आपकी पोस्टीरियर एलिवेशन होती है, ये कॉर्निया है, ये एंटीरियर एलिवेशन है, ये पोस्टीरियर एलिवेशन है. पोस्टीरियर एलिवेशन होगी तो there will be compensatory mechanism for the epithelium to get thin. लेकिन जब पोस्टीरियर एलिवेशन होगी नहीं तो एपिथेलियम क्यों थिन होगा? So there is no thinning of, there is no role actually of epithelial mapping in the form fruste, but there is a role of epithelial mapping in subclinical.
No, okay, so let me sort of recap. If you've got a form fruste keratoconus and you don't have posterior elevations, the epithelial sort of
देखिए form fruste जब आप कहते हैं ना, वर्ड यूज करते हैं, that means there is no topographical evidence, that means there is no posterior elevation. अब आप आगे चलें.
Yeah. So let me just explain, let me give you a sort of an answer to that. I agree that sometimes that can happen, yes, that you will not find even epithelial problems in a form fruste keratoconus. But the epithelial remodeling does not start based on posterior elevation. It starts on sort of corneal remodeling. So you can get epithelial changes even in form fruste keratoconus.
No,
I can show you cases.
The basic theory of epithelial, or the basic concept of epithelial thinning, is that it is a compensatory mechanism for the posterior elevation. So if there is no posterior elevation, there is no need of compensatory mechanism.
The compensatory mechanism is not for posterior elevation. The compensatory mechanism is for corneal change in its sort of its shape. So it's not necessary for posterior elevations.
There are other things. There are other things which are in practice, and it is not the epithelial mapping for the form fruste. It is actually the total cross-sectional diameter of the posterior and anterior surface. So when there is a disparity, लेकिन जब हम लोग keratoconus की बात करते हैं ना, तो जितनी दफ़ा we talked about the keratoconus, we talked about the posterior surface. Posterior elevation ज़्यादा होगी, posterior elevation ज़्यादा होगी, posterior elevation ज़्यादा होगी. But when we talk about the form fruste keratoconus, the form fruste में posterior elevation normal होगी. We concentrate more on the anterior elevation, और वो anterior elevation जो है वो आपको epithelial mapping से नहीं आएगी, वो आपको आएगी biomechanical उसके साथ आएगी, या फिर wave front aberration से आएगी. तो जो anterior elevation है, when you talk about the form fruste, then you change your mind from posterior elevation to the anterior elevation, and you more go into the biomechanics, and you more go into the wave front aberrations. तो उसमें wave front aberrations ज़्यादा होती हैं, spherical aberration होती है, क्योंकि posterior की सारी की सारी वो, और उसमें there is a disparity between, उसको कहते हैं anterior posterior surface index. Anterior का मतलब होता है कि anterior surface का जो surface area है वो ज़्यादा होता है, posterior surface का surface area कम होता है. When there is a change of that index के वो posterior anterior का surface area फ़र्क आ जाए, so that is taken for the form fruste. लेकिन आप check कर लें, there is no epithelial thinning in the form fruste. क्योंकि form fruste का मतलब यही है कि आप normal cornea.
No, form fruste का मतलब है कि एक abnormal cornea है in one eye and a normal supposed cornea in the other eye, because we still believe that keratoconus is a bilateral disease. So we don't have ways to diagnose the other eye, or it's not a bilateral disease. But anyways, we can agree to disagree, and I will read up on it. Maybe there's a gap in my knowledge, and I'll go and look it up.
जी sir.
Posterior जब फॉर्म फर्स्ट केराटोकोनस हम उसको कहते हैं जब इंटीरियर इज एब्सोल्युटली नॉर्मल बट पोस्टीरियर एलिवेशन आपकी बढ़ी हुई है, मतलब उसने शो नहीं किया अभी इंटीरियर सरफेस पर।
नहीं सर, फॉर्म फर्स्ट उसको नहीं कहते जी। जब पोस्टीरियर एलिवेशन इंक्रीज होगी और एंटीरियर एलिवेशन इंक्रीज नहीं होगी तो उसको सब क्लिनिकल कहते हैं जी। There are three terms. One is subclinical, one is suspect और one is form first है।
अच्छा, अब ये सब क्लिनिकल जो है उसको आप कहेंगे पोस्टीरियर केराटोकोनस।
क्या चीज़ जी?
सब क्लिनिकल को आप
जी, सब पोस्टीरियर केराटोकोनस को आप सब क्लिनिकल कहते हैं क्योंकि वो क्लिनिकल नहीं होता, वो टोपोग्राफी के ऊपर होता है, तो इट इज सब क्लिनिकल।
फॉर्म फर्स्ट किसको कहेंगे आप?
फॉर्म फर्स्ट है उसको कहेंगे जिसमें टोपोग्राफी के ऊपर दोनों एलिवेशन नॉर्मल है और दूसरी आई में केराटोकोनस है। और सस्पेक्ट उसको कहते हैं कि दूसरी आई नॉर्मल है और इस आई में आपको कुछ सस्पिशन हो रही है कि कोई रीडिंग ज़्यादा है या कोई एलिवेशन ज़्यादा है या कुछ या स्रैक्स है या कुछ है, तो आप सस्पिशियस, तो आपको सस्पिशन हो रही है कि दे माइट बी केराटोकोनस इन द राइट आई बट द लेफ्ट आई इज नॉर्मल, तो उसको सस्पेक्ट कहेंगे। लेकिन अगर आपकी वो आई नॉर्मल है और दूसरी आई में केराटोकोनस है तो उसको फॉर्म फर्स्ट कहेंगे।
थोड़ा सा मैं भी महफूज साहब की बात को इंडोर्स कर लेता हूँ, क्योंकि फॉर्म फर्स्ट केराटोकोनस मीन नॉर्मल आई while the other eye is basically keratoconus. So if you do epithelial mapping or pentacam whatsoever, that will comes out as normal. So form first keratoconus mean normal eye in relation to the other keratoconus eye.
हाँ, लेकिन आई थिंक मेरी बात ये है कि फॉर्म फर्स्ट हम उसी को कहेंगे जिसमें नहीं है फाइंडिंग्स क्लिनिकली, बट देयर इज अ पोटेंशियल टू डेवलप केराटोकोनस हियर। केराटोकोनस
अभी तक तो इसमें डेवलप नहीं हो चुकी है ना सर?
अभी डेवलप नहीं हुई है,
लेकिन चांसेस है क्योंकि अदर आई में केराटोकोनस है।
सर, आई थिंक वी आर टॉकिंग अबाउट ओनली द सिंगल डेफिनेशन ऑफ फॉर्म फ्रस्टे केराटोकोनस। देयर आर 3 डिफरेंट डेफिनेशंस ऑफ form fruste keratoconus. Number 1 is that what we are talking about. The one eye is normal on the pentacam and other eye has some problem. Number 2 definition is that patient come to you for the LASIK, the numbers are absolutely fine, you go for the pentacam tomography, the tomography is not abnormal but it's not normal, patient does not have any problem, hourglass patterns are not fine but still, so we can label this is the second definition of the form fruste. And the third definition of the form fruste is that cousins have got keratoconus, they underwent treatment for that, patient comes to you with irregular or oblique astigmatism, pentacam is normal, so we label this patient as form fruste and we observe this patient. So if there is, I would second Sir Tanveer and Sir Mahfouz, that if there is any change on the posterior elevation map, then it's well understood that the keratoconus starts from the posterior part of the cornea. So we cannot label that patient as a form fruste, that is a subclinical patient, and that is more.
Mustafa, if can we go for the seek cell in the form of fruste keratoconus if the other eye has got keratoconus?
If the other eye has got keratoconus,
yes.
If it is not progressing, vision is 6/6, patient does not have any problem, I will keep that patient under observation. थोड़ा बहुत नेगेटिव काउंसिल करके डराऊंगा कि भाई भागना नहीं है, हर 6 महीने बाद आना है।
अच्छा, अगर मरीज जो है ना वो प्रॉपर फॉलोअप नहीं कर सकते तो फिर?
सर, पेशेंट को नेगेटिव काउंसलिंग इसीलिए करते हैं
नहीं, बेसिकली एक है कि एक आंख में है केराटोकोनस, ठीक है, वो तो टोपोग्राफी सारे पैरामीटर्स बेसिकली है केराटोकोनस के, दूसरी आंख में बिल्कुल नहीं है।
जी सर, बट दैट इज नॉट प्रोग्रेसिव।
लेकिन इफ यू वांट टू गो फॉर द सीक सेल, पर्सनली आई थिंक दैट यू शुड गो फॉर सीक सेल इन बोथ ऑफ द आईज, राइट? Because seek cell is basically extremely harmless procedure, and if the patient cannot maintain the follow-up, I think the best way is to go for seek cell in both of the eyes.
Even in the normal depends where you are. It depends where you are and what sort of patient you've got. हमारे पास बहुत से patient आते हैं जो come from Balochistan with history of allergies and keratoconus, a family history of keratoconus. You may lose them from follow-ups. तो उसमें तो शायद ये एप्लीकेबल हो, लेकिन पीपल कमिंग फॉर रेगुलर फॉलोअप्स, तो अगर डिजीज नहीं है या शो नहीं कर रही है तो just wait and observe, I think.
So yeah, so we sort of segued into the next session. Okay, when do you advise the patient to perform CXL?
Yeah, exactly. That's very.
So that is the next question. Isliye I'm just introducing it.
Because this is a very important question. जब मैंने CXL करना स्टार्ट किया था, I had so many patients in my clinic कि डॉक्टर साहब आपने पहली मरतबा टोपोग्राफी की है और आपने हमें CXL एडवाइस किया है। हमने सेकंड ओपिनियन लिया है, उन डॉक्टर साहब ने कहा है कि हमने रिपोर्ट नहीं की है प्रोग्रेशन on the file. So this is what I think is very important. If patient has got 6-9 vision in one eye, 6-12 vision in the other eye, patient has got history and record of decreasing vision, increase in the astigmatism which is irregular, but patient has only first sitting with the pentacam, I would definitely go for the CXL.
So is just a question for you, is there any sort of age considerations?
No.
No?
Yeah, can I add? दो चीज़ें मैं ऐड करूँगा. नंबर वन, हर वक्त टोपोग्राफी आपको सच नहीं बता रही होती.
Yeah, exactly.
ठीक है, आपको क्लिनिकल जो हिस्ट्री है और एग्जामिनेशन के बाद जब टोपोग्राफी कराते हैं तो क्या ड्राई आई है वो आपको गलत टोपोग्राफी दे सकती है. क्या कॉन्टैक्ट लेंस पहनने वाला पेशेंट है जिसने बहुत अरसा पहने वो टोपोग्राफी. तो एक टोपोग्राफी पे सिर्फ एक तो इस्टेब्लिश्ड केराटोकोनस है केराटोकोनस, नो डाउट अबाउट दैट. पोस्टीरियर फ्लोट भी शो कर रहा है, एंटीरियर फ्लोट भी शो कर रहा है, उसमें तो आप CXL करोगे. बट व्हेन यू आर इन डाउट, वो आपने ये चीज़ें कंसिडर करनी है कि हमें ये टोपोग्राफी हमने किस सर्कमस्टांसिस में की. दूसरी चीज़, एज ए सेड कि मैनी ऑफ द पेशेंट्स कम फॉर सेकंड ओपिनियन विद हाई एस्टिग्मेटिज्म, और उसमें उनका के रीडिंग्स डिफरेंट होती हैं जो हमारे उसमें सॉरी महफूज ने भी कहा उन्होंने कि के रीडिंग्स आर सेकेंडरी थिंग्स. के रीडिंग्स को मत देखें. तो एस्टिग्मेटिज्म हाई है और उनको CXL की एडवाइस की गई है. क्वाइट अ लॉट ऑफ पेशेंट कम फ्रॉम आउटस्कर्ट्स और इवन फ्रॉम द सिटी. तो उनको आपने एडवाइस देनी है कि आपको CXL की ज़रूरत नहीं है. पेशेंट गेट कन्फ्यूज्ड हियर. हमारे यहाँ इतने डिफरेंट ओपिनियंस हैं कि पेशेंट गेट ओपिनियन, लेकिन डॉक्टर साहब वो तो ये कह रहे थे, आप ये कह रहे हैं. तो फिर हम कहते हैं कि आप क्या करें. अब आप तीसरे डॉक्टर से वो जाएंगे, मशवरा करेंगे. तो इसमें हमें बहुत एक तो माइंड ये सेट होना चाहिए कि वी आर कॉर्नियल पीपल. आर वी कॉर्नियल पीपल? या हम सब कुछ कर रहे हैं और हम सब कुछ करते रहेंगे. तो कॉर्निया पीपल, अगर आप श्योर नहीं हो तो प्लीज रेफर टू दोज हु डू कॉर्निया मोर एंड लेट देम डिसाइड कि वेदर टू डू और नॉट, इंस्टेड ऑफ पुटिंग डाउट्स इन पेशेंट्स माइंड. और आप यकीन करें कि बहुत पेशेंट कंफ्यूज होते हैं एंड दे डोंट टेक 1, 2 or 3 ओपिनियन, दे जस्ट कीप ऑन रनिंग आफ्टर ओपिनियंस. और उसमें कोई जेन्युइन डिजीज पेशेंट होगा, दे विल सफर.
थोड़ा सा आप लोगों को
वो जमहूरियत पे चलते हैं.
हाँ सर, थोड़ा सा आप लोगों को ज़रा आगे लेके जाता हूँ. ठीक है कि वी हैव डन CXL फॉर मेनी डिकेड्स, राइट, एंड इट इज़ अ गुड ट्रीटमेंट, नो डाउट्स. But the thing is, after the designing of the donor refractive lenticule transplantation, which is one of the new technique, and you will see a short video after a while, actually I made some new guidelines, right, for doing CXL in every keratoconus patient. If you do the CXL and you repeat the pentacam after 1 year, after 2nd year, in most of the patient, the keratoconus by nature is basically a progressive disease. So personally, according to my own protocol, right, and you people will appreciate when you see the video, we should first go for donor to refractive lenticule transplantation in every patient who is having keratoconus, right? And we can do CXL within the same month to give more stability and good visual result with less harm. Or in donor to refractive lenticule transplantation, the rejection rate is extremely minimal. And when you see the video of the second version, actually they contain the Bowman layer. And you know that in the Bowman layer, basically it's contained only the collagen. There's no keratocytes. So rejection rate is extremely minimal. So if you go for the CXL after that, I think, and personally I have observed the patient, they will go a very good response. Even if you reach up to the age of the 30, you did the CXL at the age of the 5-6 year, you wait for up to 30 year. This is a long way. So with CXL, you cannot control the keratoconus alone. So the new treatment modality, we will discuss this somehow in the wet lab course as well as in the video.
नोमान, मैं सिर्फ एक बात ऐड करूँगा कि CXL people do epi on, epi off, depend on preference. एपी ऑफ जो हैं उसके भी रिजल्ट्स और पब्लिश्ड हैं, लेकिन FDA के पास एक नई
Sir, I would just stop it right because the next slide is about epi off, epi on. So we'll talk about that. I just want to
करना चाह रहा हूँ कि एपी ऑन एपिऑक्सा इज मेडिसिन जो कि बहुत रैपिड एब्जॉर्प्शन होती है एपी के बगैर। FDA के पास है, FDA ने अभी अप्रूव नहीं की है, बट होपफुली FDA विल अप्रूव दैट एंड दैट विल बी अनदर सॉर्ट ऑफ न्यू डोर ओपन फॉर CXL, जो कि रैपिड CXL होगा विद a new medicine.
There is another thing that's been approved actually by the FDA, and that's called SV-Med. These are the eye drops. ये copper sulfate के eye drops होते हैं, and they do the cross-linking without doing the ultraviolet or the riboflavin. तो आप पेशेंट को जैसे एंटीबायोटिक के स्टेरॉइड के ड्रॉप्स देते हैं, अब मुझे डोजेज उसकी पता नहीं है कि हाउ मेनी टाइम्स अ डे वो है, लेकिन दे आर कमिंग इन टू द मार्केट एंड दे विल जस्ट क्रॉस लिंक। तो उसमें क्रॉस लिंक का ये होता है कि अभी तो आप राइबोफ्लेविन डालते हैं, फिर उसमें अल्ट्रावायलेट लाइट डालते हैं, उसमें आपने कुछ भी नहीं डालना, आपने सिर्फ पेशेंट को 3 times a day ड्रॉप्स देने, एंड दोज ड्रॉप्स दे क्रॉस लिंक द अमीनो टर्मिनल्स विद द प्रोटियोग्लाइकेंस ऑफ द कॉर्निया। तो वो अभी नई चीज़ आ रही है, तो दिस CXL विल बी गॉन इन द नियर फ्यूचर एनीवे। तो SV-Med आ रही है, और एक दूसरी मेडिसिन है जो कि अंडर रिसर्च है, उसको EV कहते हैं, मुझे उसका नाम भूल गया, लेकिन देयर समथिंग एक्स्ट्रा सेलुलर वेजिकल्स और समथिंग लाइक दिस। तो वो स्टेम सेल डिरीवन है, वो भी ड्रॉप्स की सूरत में आ रही है, बट द CXL विल बी गॉन इन द नियर फ्यूचर एनीवे। और दूसरा आप CXL को एक और चीज़ याद रखें, आप सीन पेशेंट्स, लोगों ने CXL किया होता है 40-year-old पेशेंट का, 40-year-old पेशेंट का, 35-year-old पेशेंट का आप CXL इसलिए करते हैं कि प्रोग्रेशन रोके, उनमें तो ऑलरेडी प्रोग्रेशन रुकी होती है, वो तो ऑटो क्रॉस लिंक हो जाते हैं, नेचुरली क्रॉस लिंक हो जाते हैं। तो अगर आपने 35 के बाद वाले का करना है तो यू नीड टू सी द प्रोग्रेशन, और अगर 35 से कम वाले का करना है तो फिर आपने केराटोकोनस देखना है और करना है, फिर वेट नहीं करना कि वो 6/9 से 6/18 हो जाए तो मैं करूँगा, क्योंकि मैंने प्रोग्रेशन डॉक्यूमेंट करनी है। आप एक पेशेंट आपके पास 6/9 6/12 के साथ आया है, आपने उसको CXL कर दिया है, दूसरे का 6/9 6/12 के साथ आया और आप वेट करते हैं कि प्रोग्रेशन होगी, तो जब 6 महीने बाद साल बाद आएगा तो 6/12 6/18 होगा, तो वाई यू वांट इट टू गो टू डिटेरिएट द पेशेंट। तो अगर आपके पास एविडेंस है कि उसको केराटोकोनस है तो डू इट, लेकिन अगर 35-40 के बाद आता है तो देन वेट फॉर द एविडेंस, क्योंकि वो तो क्रॉस लिंक हो चुका होता है।
So that's why I asked the question कि एज जो है उसका कोई रेलेवेंस है कि नहीं। फॉर मी एज हैज़ अ ह्यूज रोल कि अगर वो 30 से कम, आप 35 है, मैं 30 से ऊपर प्रोग्रेशन देखता हूँ, 30 से बिलो आए।
Usually it depends upon the gender. In female you can do the CXL after the age of the 30 year due to the hormonal changes.
Okay, and that's a good point. Also, pregnancy can cause a bursting of keratoconus as well. Achha, now just for food for thought, I'm just going to throw this out there. There's a very prominent doctor in the world. I think all of you may have heard his name. He's known as Damien Gartinel. He's from France. He's the head of Rothschild Foundation, also the creator of trifocal lenses, and he does a lot of work in keratoconus. उन्होंने एक movement 3 से 4 साल पहले शुरू कराई थी, and it was known as no rub, no cone. So what he advises, it's just food for thought. I don't follow this, but it's just a food for thought. Okay, if you get the patient to stop rubbing his eyes, and if you get this patient to stop sort of sleeping on that side जहाँ उसको keratoconus है या eye पे pressure नहीं करे, तो आपको CXL करने की कोई ज़रूरत नहीं है. That's what he's saying.
The keratoconus reverses, and later on you can find a normal pentacam of that patient.
So that is another food for thought. Okay, maybe we are over CXLing, and if the patient is above 30 or 35, whatever parameter you want to set, please observe for progression. उससे कम आप CXL कर रहे हैं, ठीक है, कोई मसला नहीं है, but please observe for progression if he is above 30, and do keep in mind the no rub, no cone. It is extremely important, and it can actually, in early cases, reverse keratoconus as well.
नमान इसमें एक चीज़ बिल्कुल सब्जेक्ट से हट के सिमिलर थिंग, सिस्टर्ड मैकुलर एडिमा एंड डायबिटिक्स, उन्होंने एक रिपोर्ट थी कि स्ट्रिक्ट डायबिटिक कंट्रोल ओनली, नो एंटीवायरस, स्ट्रिक्ट डायबिटिक कंट्रोल ओनली, फॉलोइंग मंथ्स में वो सेटल खुद हो जाता है.
So now going on to what protocol do you follow for CXL, and why do you follow it? Anyone?
Accelerated epion.
Accelerated?
Epion.
Epion. Sir?
Accelerated epi-on.
Epi-on?
Yes.
The same.
Okay. Can I ask why epi-on?
I used to do epi-off. All the complications, आप मुझे juniors बताएं कि CXL की क्या क्या complications होती हैं? Epithelial defect होता है, microbial keratitis होता है, और क्या haze होता है, और क्या होता है? जी, non-healing epithelial होती है. ये सारे के सारे जितने भी side effects हैं, ये सारे epi-off में होते हैं.
सर ये हो चुके हैं हमारे साथ.
कभी आपने सुना है कि ऐसा कोई चीज़ epi-on में हुई हो? That's the one thing. कि epi-on इसलिए करता हूँ कि और मैं पहले दोनों करता था. epi-on इसलिए करता हूँ कि there was a recent meta-analysis which was published in 2024, November 2024 में हुआ था, and that was the meta-analysis of 15 cross-sectional prospective cross-sectional studies. उसका meta-analysis हुआ था, and the results of the epi-off are the same as the results of epi-on. और because now जब result same आ गए तो there was only difference was the cost. उसकी cost एक 5-10 हज़ार रुपये ज़्यादा होती है, लेकिन जब आप इतनी cost में कर रहे होते हैं तो 5-10 हज़ार से फ़र्क नहीं पड़ता. But you don't, मतलब मैं epi-on कर रहा हूँ पिछले 3-4 सालों से. I've never seen any patient have any complication with CXL.
अच्छा सर, so the meta-analysis की आप बात कर रहे हैं, उसका follow-up length क्या था?
उसका मेरे पास पेपर पड़ा हुआ है मेरे लैपटॉप में.
10 years. I have read that meta-analysis. By the end of 10 years, the outcome of epi-on and epi-off was same.
उसमें एक Chinese.
I would like to send me that paper.
एक Chinese है और एक Italian है और एक तीसरा है, 2-3 authors हैं उसके. लेकिन उसके ऊपर पूरा वो उनका वो meta-analysis है. और after that has actually reinforced my practice कि epi-on करना है to avoid all the complication. क्योंकि आप epi-off करते हैं, contact lens लगाते हैं, contact lens में debris आता है, haze आता है, infection होता है, ये सारा कुछ होता है. तो epi-on में आप pick करते हैं, patient चला जाता है. And the evidence is we don't go by our clinical impression. The evidence tells you that the results are the same. So if the evidence tells you, then we need to go for the evidence anyway.
Okay. So for me, sorry.
I sort of agree with it. I used to do epi-off. लेकिन मैंने 2 बहुत खतरनाक infections देखे थे. Not done, referred by someone. Epi-off के बाद severe microbial infection, scarring, ultimately corneal transplants. दूसरी बात यह है कि जो लोग epi-off करते हैं उनके लिए अच्छी खबर है ये जो मैंने अभी बताई. Hopefully end of this year FDA approved epi-on technique जो है एपीऑक्सा जो है वो अप्रूव हो जाएगी विद सप्लीमेंट ऑक्सीजन. तो आपको फिर इस डिबेट में शायद पढ़ना ही नहीं पड़ेगा.
मेरा तो ये एडवाइस है कि अगर epi-on की रिजल्ट कम भी हो फिर भी इसको करना चाहिए, क्योंकि इसकी कॉम्प्लिकेशंस नहीं हैं. जिस चीज़ की कॉम्प्लिकेशन न हो वही प्रोसीजर होनी चाहिए. इफ़ यू गॉट अ वेरी गुड प्रोसीजर, वेरी गुड रिजल्ट, बट देयर इज़ अ लॉट ऑफ द कॉम्प्लिकेशन, वी शुड नॉट गो फॉर दोज प्रोसीजर.
देखिए आप epi-off क्यों करते हैं वैसे? मुझे why you want to do epi-off?
Okay, so I've stopped doing epi-on. मैं पहले epi-on करता था.
अच्छा, हम करते इसलिए थे to have the better absorption ना. Better absorption के लिए करते तो और तो कुछ उसका epi-on off का कोई और तो रीज़न नहीं है ना. तो when you have got the vehicles, अभी आजकल जो है वो डेक्स्ट्रैन है, मिथाइल सेलुलोज है, ये vehicles हैं. तो those vehicles are so good that वो ट्रांसपोर्ट कर देते हैं through the epithelium. तो जब epithelium के थ्रू राइबोफ्लेविन ट्रांसपोर्ट होके कॉर्निया में जा रही है तो why to scrap of the epithelium?
So there is another reason for not doing epi-on. The way cross-linking works is it requires a lot of oxygen in the cornea. So if it's not just about the absorption of the riboflavin, it's about the presence of oxygen. So there have been studies that have shown that epithelium is the highest oxygen sort of capacity taking layer. So when you do an epi-on procedure, when you put the riboflavin in, most of the oxygen is sort of taken away from the riboflavin, from the epithelium, and that is why sort of those oxygen masks came into being a couple of years ago, to sort of restore that oxygen back into the riboflavin, so that you can have the cross-linking effect. Without oxygen, you will not have cross-linking effect. So for me, I have actually gone the opposite way. I've stopped doing epi-on, and I'm not aware of the 2024 meta-analysis. वो मैं जाके देख लूँगा, मुझे exactly नहीं पता है. But in terms of the other studies that I've seen, outside of that meta-analysis, epi-off is clearly a better procedure, and there's a difference in opinion whether you go to European people and versus the US people as well.
There's another thing used in approved by the FDA that's called CXL iontophoresis. So what they do, iontophoresis, I mean, I don't know whether it's available in Pakistan or not, I don't think it is. है तो उसमें वो हल्का सा करंट देते हैं, तो that electrical current that increases the permeability of the, तो वो जो आप ऑक्सीजन की बात कर रहे हैं, I think it's not oxygen, it's oxygen radicals.
Absolutely.
हाँ, वो जो ऑक्सीजन रेडिकल्स निकलते हैं ROS जिसको कहते हैं, तो these oxygen radicals but they dissipate, वो मुझे मैंने उसको पढ़ा है, लेकिन the proof of the pudding is in eating. तो जब आपके पास मेटा एनालिसिस आता है, which is the most effective support or the evidence, तो मेटा एनालिसिस जो होते हैं ना, पेपर आते हैं, 2 पेपर आते हैं, 6 पेपर आते हैं, फिर क्रॉस सेक्शन स्टडी होती है, फिर उसके बाद कि आखिर में जाके मेटा एनालिसिस आता है. तो जब मेटा एनालिसिस आपको एक चीज़ को कंफर्म कर देता है, तो आई थिंक वी शुडंट बी डूइंग the other way.
That's why I'm asking for the papers, because meta-analysis के बारे में तो we can talk all day, because meta-analysis की quality में बहुत ज़्यादा फर्क होता है from one meta-analysis to the other meta-analysis.
मेरे लैपटॉप में मैं आपको सेंड कर
Yeah, please send.
Sir, the most
Maybe I'll change my practice.
The most important thing is that epithelium itself. Yes, sir.
क्या चीज़? सर वो मेटा एनालिसिस ने मुझे पता नहीं है.
Sir, isotonic you can use it, dextrin and dextrin free. So there are multiple studies, and उसमें उन्होंने mix किया हुआ है. They are actually comparing epi on with epi off. So they are not comparing the vehicles. So and what I want to convey here is that the most important thing, epithelium is actually a God-given natural barrier which actually halts the complication of UVA light. I had a patient. We did AP of, sir. Sir, isotonic market में available है with dextrin, without dextrin, दोनों available है. Sir, I use it without dextrin. Yeah, dextrin free.
आजकल जो मिल जाती है वो करते हैं, क्योंकि आजकल शॉर्टेज है.
रिपोर्ट का मसला है मगर.
सर हाइपरमेलोज वाली मिलती है मार्केट में. इट इज़ 20% हाइपरमेलोज होती है और साथ में उसमें टेट्राकेन होती है. आई थिंक मुझे एग्जैक्टली याद नहीं है, लेकिन इट्स इटालियन मेक. सर मैं आपको फ़ोटो भिजवा दूँगा.
सर आप भेज दो.
आपसे हम लोग सीखते हैं, लेकिन आप ये मैं आपको फोटो जी.
No, not. Yes, sir. Sir, पेश के
सर के thin cornea की वजह से.
मेटा-एनालिसिस की तो बात कर रहे हैं, बट कौन सी वो लोग यूज करके उन्होंने कहा है कि
उन्होंने व्हीकल
सर व्हीकल तो नहीं था, एक्सेलरेटेड एपिऑन CXL था, तो मुख्तलिफ लोगों ने मुख्तलिफ व्हीकल इस्तेमाल की होंगी. अब वो मैंने पूरा पेपर मुझे याद नहीं है, लेकिन द रिज़ल्ट वाज के एपिऑन एपी ऑफ इज़ द सेम, लॉन्ग टर्म रिजल्ट सेम होते हैं. मैं ग्रुप में लगा दूंगा, कॉर्निया के ग्रुप में, तो सबको मिल जाएंगे.
Okay. So, what are other ways जिसमें आप केराटोकोनिक इंडिविजुअल्स को हेल्प करते हैं other than CXL?
ये जमान शाह साहब बताएंगे.
बताइए सर.
What sort of help to halt the progression or for the refractive or visual?
Halt progression के लिए तो आप CXL ही है ना. You don't have anything else. What other tools do you have? What do you use?
आप केयर्स बताएंगे.
आप थोड़ा सा वो केयर्स वाली स्लाइड निकाल ले, उसके बाद मुझे
so
थोड़ा सा मौका दीजिएगा. वो वीडियो भी चल जाएगी और इसमें मैं जो चाहता हूँ अपना मैसेज लोगों तक पहुँचाना चाहता हूँ वो भी सब सुनेंगे.
So there are many ways. This is not just CARES and DRLT and whatever we are discussing. So there are ways of doing things, different ways. So we're talking about surgery because we're all surgeons here. But please, एक चीज़ दिमाग में रखें, नॉन इन्वेसिव मेथड आपके पास है, एंड इट्स नोन एज हार्ड कॉन्टैक्ट लेंसेज. तो अगर इफ़ यू डोंट हैव एनीथिंग और इफ़ यू हैव अ पेशेंट जो अफोर्ड नहीं कर सकता, उसको प्लीज़ हार्ड कॉन्टैक्ट लेंस की फिटिंग के लिए भेजें, get him to, these hard contact lens can do a lot of miracles. You can bring them down to 6.9 from 6.36. They really do help. Then you have other ways of doing things. There are tissue adding procedures. Just DRLT ho gaya, CARES ho gaya, intracorneal rings intacts. Just because CARES or wo aa gaya hai, doesn't mean that intacts. A lot of people are still doing intacts and they're getting phenomenal results. Then you have tissue subtracting procedures. Those are known as topo-guided PRK. So there's different protocols like Athens protocols and Creton's protocol. We have some data on that also we'll share, where we've sort of regularized the cornea using topo-guided PRK. Or बहुत अच्छा tool है. Then obviously at the end, you've got the end of the spectrum, you've got DOLC and PKP. Sir.
मैं सिर्फ एक ऐड करूँगा again, people who are starting or new in this field, जब भी आपके पास केराटोकोनस का पेशेंट आए, उसको कोई भी ट्रीटमेंट करने से पहले प्लीज़ मेक श्योर कि यू हैव सेंड देम फॉर कॉन्टैक्ट लेंस ट्रायल. एक कॉन्टैक्ट लेंस ट्रायल ज़रूर करा लें. उनकी विजन है 636, 624, वट एवर. Is it improving to, अगर तो क्योर keratoconus है, because sometime there have been cases of amblyopia और कॉन्टैक्ट लेंस लगाने के बाद although everything is fine वो improve नहीं हो रही है. तो ये आपको पहले पता होना चाहिए कि आप क्या विजन क्या करने जा रहे हो पेशेंट के साथ. पेशेंट को पता होना चाहिए. पेशेंट फील कि दे कैन वेयर कॉन्टैक्ट लेंसेज. पेशेंट फील दैट दे हैव इम्प्रूव्ड विजन विद कॉन्टैक्ट लेंसेज. अब जो आगे ट्रीटमेंट होगी वो इम्प्रूवमेंट के लिए होगी. But make sure that you do that trial and then go for any treatment either for halting the situation or improving the vision.
सर की बात को मैं आगे बढ़ाऊंगा कि जब भी मैं DRLT प्रोसीजर कर रहा हूँ तो इससे पहले मरीज़ को मैं भेज देता हूँ कि इसकी पोटेंशियल विजुअल एक्विटी मुझे चाहिए. अगर इसमें विजन न हो, एम्ब्लायोपिया हो, तो कैसे मैं प्रोसीजर कर लूँ? क्योंकि प्रोसीजर का मतलब ये है कि we want to improve the vision of the patient. Secondly, we want to give some strength and we want to have the contact lens tolerance. So अगर इनमें से एक भी मिसिंग हो तो मैं मरीज़ को बता देता हूँ कि ऑपरेशन के बाद आपकी विजन नहीं आएगी.
That's absolutely true. तो ये जैसे केस है, 26-year-old female counting vision, no corneal scarring, high drops. Obviously, if you have scarring or high drops, you can't do any of the procedures. -6 का केस है. So you can go for any of these cases. But I purposely chose a fairly advanced keratoconus. इसकी जो thickness है in the center, it's about 347. I recently did a case with a with a thinnest local cornea of 250. CARES case मैंने उसमें किया है. तो उसकी रिजल्ट मैंने अभी 2-3-4 दिन पहले किया, तो रिजल्ट नहीं आया तो I didn't put it here. But you can do these things in fairly advanced cases. तो ये patient का ये result था. So you've got someone who was counting finger, who had an over 73 K reading, came down to 57.5 and went from counting finger to 612. इसकी बड़ी interesting कहानी ये थी कि मैंने इसको खुद before I started doing CARES, मैंने उसको DALC का एक idea दे दिया था back in last year September. Then I started CARES. मैंने इसको 3-4 महीने delay किया. I did a lot of CARES and then I did this case, and you can see the result what we've achieved with this particular case. Now in our initial cases हमें थोड़ा सा cosmesis का problem हो रहा था because मैं graph खुद बना रहा हूँ and we were getting these whitish sort of graphs and I didn't understand why. So these are more recent cases. आप देख सकते हैं कि the graphs are absolutely clear. You can see. I won't tell you why because we are going to publish this soon. But we are getting absolutely clear graphs and बिल्कुल perfect cosmesis almost. Some more cases जो मैं दिखा रहा हूँ कि we've taken a patient who was relatively good vision from 636 to 612 and you can see that particular case कि इसमें तो आपको ring भी बहुत मामूली सी नज़र आ रही है because this was a picture taken later and you can not see the ring at all. The नीचे वाला case was one of my earlier cases, but you can see the vision improvement going from counting finger all the way to 615. So this is what we can offer with CARES today, and Sarah will also show what we can do with DRLT. So just a quick surgical video of how we're doing CARES. So 2x per head, I marked the axis where I want to put them in. We take the tunnelizer, we open the channels, then this is the tissue that we're implanting. टिश्यू को हमने मार्क किया हुआ है विद सर्जिकल मार्कर, ताकि हमारा बोमिन्स जो है हम सेंट्रली प्लेस कर सकें, बिकॉज दैट्स वेयर यू आर गेटिंग द ऑप्टिकल सॉर्ट ऑफ जोन. And once we sort of, so just a very quick overview, the femto makes one incision, तो second incision मैंने खुद दिया, and that was the case, and you can see that result. And I showed you that this case was, this case was ये वाली individual, so the second eye, this person. So we are getting beautiful results. So Dr. Zaman wanted to show DRLT.
Actually, what was the logic behind by introducing some new technique? The reason was that if you look at in the rings, that is quite visible, and keeping in mind a lot of the complication. Come to the case, right? I have discussed this case with the designer, Dr. Susan, yes? And actually the basic problem was the visibility of the tissue. That's look cosmetically unacceptable. And if you check the visual acuity, of course the patient will have 6/12, 6/9 vision, but that is extreme poor quality of the vision. We don't want any glare, any spherical aberration. If it is less, the patient will be happy. If you got high spherical aberration, high photophobia, the patient can't open the eyes in the sunlight. Then what's the need for doing this procedure? Now the design, so far we have got 4 design of the DRLT. You people will see the first version that is available on the YouTube. The second version is again available on the YouTube, right? And you will shortly see the video. The third and the fourth version of the DRLT is still awaited. And that is much more superior version of the DRLT procedure for keratoconus. It is very difficult to manage the keratoconus. Nobody can manage the keratoconus. At least we can help someone. Okay, can you please start the video? This is the second version for which I use the donut, for which I use the lenticule from the whole globe. This is the whole globe, right? And I have made an artificial orbit. This is the artificial orbit where I want to put, and this is the second version. In the first version, we use the smile-derived lenticule. Now this is the epithelial scraping, and this now the docking, and this is the patient eye, right? Now we have set the protocol for this 120 micron thick tissue, 8 millimeter in diameter, and central donut is 4 millimeter. We want to create a new optical zone for the keratoconus patient. And the diameter is kept 8 millimeter because we don't have the transition zone. And the globe-derived lenticule, this is how we remove the lenticule. And in smile-derived, we got the transition zone, which is much more helpful in mesopic people. While mesopic people, the diameter here is kept as 8 millimeter. Now we have removed the 120 micron. We are staining the lenticule. And if we transplant this lenticule, it will be of no help until and unless we make the donut. The basic theme lies, because this was practiced so many decades ago, the lenticule transplantation, but that doesn't work. The only thing which is important, and that is the donut shape, right? And in the second version, it doesn't augment the cone. In the third version and in the fourth version, there is some augmentation of the cone as well. Now this is the patient eye. We use 2 docking systems, one for the donor, one for the patient. Now this is creation of the corneal pockets for the donut lenticule implantation. And the basic themes, the basic aim behind this is the negative meniscus. We want to create a negative meniscus. Until and unless there is no negative meniscus, it will not work. Because adding the tissue to the cone will make it more steep. Adding tissue to the paracone will steepen that area, will flatten that area. And at the same time, it will flatten the cone, and you got a good visual result. And the advantage is that this tissue is not mechanical only. In CARES and in CTEC intakes, whatever, the tissue, there is a mechanical inlay. If you look at this donut, there is a biomechanical integration in first version of the DRLT, even on the slit lamp, you will try to find out where is the tissue, but you will get an excellent result. So because there is biomechanical integration to the host cornea, while in case you are seeing visible tissue, whitish color tissue, all the time, anywhere. But if you look at this thing under the slit lamp, it will be extremely difficult even to follow under the slit lamp. Here we have kept the thickness is 120. In the third version, we will be increasing the thickness of the lenticule. And at the same time, we will augment the cone as well. That will further be much more beneficial for the keratoconus. Now, if you see, this is the unfolding in spinal lenticule. The unfolding is extremely difficult. Even the insertion is difficult. But in globe thyroid, usually the unfolding is extremely easy. And this is the final step. We have concluded the procedure. We have made a new optical zone, and we are getting good results. And today we will be doing a wet lab course in the Hashmanis Hospital, and hope most of you will join us. And this is the first post-op day. And I have seen the 13th post-op day of this patient who has got base corrected was 636. Now, without glasses, this patient has got 612 vision. Usually the patient, they are extremely happy in the DRLT procedure because of the improved quality of vision. We need quality. We don't want vision. We want quality of vision. Thank you very much.
Yes, I think it's a wonderful procedure, and I think it's a wonderful thing that we have these multiple procedures being developed for keratoconus.
And one thing more, that I have completed one of the book on DLT. It is of 139 page, explaining everything about DLT, and hope that it will change the scenario from all those lamellar procedure. If suppose we go for DELC procedure, right? DELC is a new procedure, very good procedure, but we are applying 15-20 sutures. They are non-biological material. In young individual, most of the time, we are doing DELC procedure. The suture, they get loose, they vascularize, they get infected, there's a high irregular astigmatism. You remove the suture again and again, or suturing the patient again and again. When you want to ship the patient to the OT for suture removal, there is abdominal pain to the patient. All the time, the patient is worried. This procedure complete within 10 minutes. On topical anesthesia, there is no need for general anesthesia or peribulbar anesthesia.
Yeah. Thank you, Dr. Zaman. I think that was a very good sort of overview, and inshallah we'll be doing a wet lab for the DRLT procedure today at Hashmanis at 3 o'clock. Yeah, so...
one thing I would like to mention, the wet lab course is extremely difficult and discouraging, but the live surgery, the actual procedure is extremely easy. So I will be happy, so that the people should invite me for live procedure.
Okay, so moving on now, this is a case that was shared by, sorry? Okay, so this is a case that was given by Dad. This is one of the other procedures for keratoconus. Earlier, they developed something called the Athens, Kratil, or Tel Aviv protocol. This is a tissue removing procedure. What it does is basically sort of reshifts the biomechanical profile of the cornea, and it gives a better sort of refractive result. So, so the protocol itself is that you're using, you remove the epithelium, you use an excimer laser like your LASIK excimer laser to basically remove to ablation depth of about 50 microns. You can use mitomycin C, but make sure that you have residual stromal bed of greater than 400. So this is sort of the high order aberration map. Anyone that does topography guided LASIK is very sort of aware of what this is that you can see that this is almost 50 microns of coma that's developed in someone of keratoconus. So you ablate that coma, you ablate the cone a little bit so that you can regularize the cornea. And Okay, and you can see that what the post-op results are. You got a much better and much improved topography, and again, preoperative, postoperative changes in another case, and you can see a much more improved topography. So I think we can conclude the session here. I want to thank the panelists for taking out their time and energy to come and teach us keratoconus. I think we had a very healthy discussion. Thank you very much. I would like to call Dr. Misbah to sort of end the session. हाँ शील्ड हैं उधर पड़ी हुई बाकी आप हम भी नीचे चले जाएंगे.
Thank you very much, Noman, for finishing well in time. And please have a seat for another 4 or 5 minutes. We're going to conclude 10 minutes before the namaz. So please don't go. I thank you all on behalf of the Hashmanis Hospital and on behalf of the OSP Karachi. And the president of OSP Karachi is here, Professor Saeed. I would like to invite him here to say the vote of thanks, and after that we'll distribute shields.
Assalamu alaikum everyone. Thank you very much, Hashmanis. Aapka session khasa acha raha. This was the last workshop, which was theoretically more involving the person, because of namaz ke baad honi hai, that is the Hashmanis, jo ke this is little bit practical. I think this informative type of session should carry on like this. मैं देखा था बहुत सारे residents और बहुत junior consultants से जिनका interest develop हो चुका है with the passage of time in all these type of activities, जो कि बड़ा ही fruitful लगता है मुझे, क्योंकि obviously आप लोगों ने संभालना आगे सब कुछ. हम लोग आहिस्ता आहिस्ता निकल जाएंगे आगे और juniors का काम है संभालना. Noman is a very nice and very upcoming moderator, बहुत अच्छा moderate कर रहे हैं. तो I'll say thank you and I welcome all of you, because KAROPHTH officially start हो गई है और दोपहर में सेशन के बाद इंशाल्लाह शाम में we'll see you in the inaugural ceremony. Allah Hafiz.
There are some shields for the presenters. So may I first invite Professor Mahfouz to kindly come and take his seat. May I invite Professor Saeed to come and please distribute the shield. And Dr. Sharif Hashmani also, please, for distribution of shield. I think I must especially thank Professor Mahfouz, because he's always very kind and always comes to our pre-Congress Keratoconus and refractive surgery workshops. Next, I would like to invite Professor Dr. Zaman Shah to kindly come and take his shield. जल्दी लेके आओ तनवीर. May I invite Dr. Tanveer Chaudhary now, please. I'm thankful to Dr. Tanveer because in spite of a very pressing commitment, he decided to stay and take part in this con. Next is Professor Isra Bhutto, please. May I call Professor Isra Bhutto to collect his shield, please? Next would be Dr. Mustafa Kamal. हाँ है भाई. डॉक्टर असफर नफीस प्लीज. नहीं है तो कौन कलेक्ट करेगा असफर नफीस शील्ड? आप में से कोई आ जाओ. हाँ, डॉक्टर नोमान की शील्ड भी है ना? हाँ हाँ, दिस इज फॉर डॉक्टर असफर. And Dr. Noman Hashmani, please. And last but not the least, the host of this session and the main force behind it, Dr. Sharif Hashmani. डॉक्टर सईद प्लीज. एक शील्ड प्रोफेसर सईद के लिए भी है. मज़र आओ भाई. जिशान आप भी आ जाएं.
मैं एक बात कहूँगा, सॉरी मैं इंटरप्ट कर रहा हूँ. ये लोग जो प्रेजेंट करते हैं ना, ये बड़ी मेहनत से करते हैं. ये लोग जो पैनल बनाते हैं बहुत मेहनत से बनाते हैं. इतनी कंजूसी तालियों में आपकी है जिसका कोई हिसाब नहीं. कोई पैसे नहीं लगेंगे, कोई पैसे नहीं लेगा आपसे.
हाँ, सईद साहब की शील्ड देना जरा. सईद साहब नाम बाद में लिखवा लीजिएगा. नहीं नहीं, आप प्रेसिडेंट जो हैं. And then one for Dr. Zishan Kamil, please. सईद को और जिशान कामिल को वैसे ही शील्ड नहीं दे रहे हैं. इन लोगों का बहुत बड़ा हाथ है इन सारी चीज़ों के अरेंजमेंट में. वो बाकी डेफिनेशंस आप वो बता दीजिएगा कभी. प्रोफेसर मजहर ऑल्सो. प्रोफेसर मजहर. प्रोफेसर मजहर जो हैं वो प्रेसिडेंट इलेक्ट हैं और आज उनका आखिरी दिन है प्रेसिडेंट इलेक्ट के तौर पे. परसों से? ओ हाँ, 2 दिन है भाई अभी. 2 दिन के बाद ही प्रेसिडेंट हो जाएंगे. हो गए भाई. सईद को दे दिया. सईद को दे दी. सईद को दे दिया. बस यार ठीक है. ठीक है भाई.
आशमानी का कोई प्रोग्राम मतलब विश्वास साहब के बगैर सोच नहीं सकते. थैंक यू सर. थैंक यू वेरी मच. थैंक यू.
अच्छा भाई, बहुत बहुत शुक्रिया आप तमाम हजरात का और ख़वातीन ख़ास तौर पे, क्योंकि ख़वातीन ज़्यादा है यहाँ पे. तो अब नेक्स्ट सेशन जो हमारा है वो हाशमानीज़ हॉस्पिटल क्रिफ्टन ब्रांच में है. और जैसे अभी आपने एक वीडियो देखी है, ये जो नया प्रोसीजर डोनट इंसर्शन का है, ये इंशाल्लाह वहाँ पे लाइव दिखाया जाएगा. तो आप सब वहाँ भी तशरीफ़ लाएँ. और एक बार फिर मैं हाशमानीज़ हॉस्पिटल की जानिब से और OSP की कराची की जानिब से आप तमाम हजरात का शुक्र अदा करता हूँ. बहुत बहुत शुक्रिया. एंड मे गॉड ब्लेस यू.